Ma'am, we are live in 3, 2, 1. Please start, ma'am. We are live.
Namaskar and a very happy Diwali to all of you present here. And a very warm welcome on the second day of Breast Cancer Management 2022 and beyond. With immense pleasure, I would like to invite Dr. N. Aditya Murali, who is Consultant Medical and Hemato-Oncologist, Esther CMI Hospital, Bangalore, for the welcome and introductory note. Over to you, sir.
Good evening and welcome to all my colleagues for joining us on a wonderful Friday evening. Pardon my disturbed state, but that is Bangalore traffic for all of us. In any case, I hope that over the next 2.5 hours, you will have a very fruitful discussion on how to take the leap forward of managing breast cancer in the 21st century, especially how do we deal with personalized therapy in breast cancer in terms of targeting the hormone receptor pathway, in terms of targeting the HER2 pathway. What are the newer molecules that we have, and are these new molecules only limited to the advanced setting, or can we do that even in the early breast cancer setting? So I'm very proud to have Dr. Rahul Sood as the chairman of our scientific organizing committee, and the ball is ready. I would like to invite Dr. Prasad Narayan to take over on the first talk. Please, Dr. Prasad.
Thanks, Dr. Aditya, and thanks, Dr. Rahul, for this opportunity. So I will share the screen. So is it visible, the slides?
Yes, sir.
Yeah. So in the next 15 minutes or so, my job is to discuss the metastatic breast cancer management in the hormone positive HER2 negative scenario, and in line with the conference topic, we will be talking about the present situation and beyond. So first 5 minutes, I will be discussing on the first line and second line therapy, which are available now. Then slightly beyond CDK4/6 inhibitors, the approved therapies, and then newer agents, the oral SERDs, the PI3K, PI3K, AKT pathway, and the antibody drug conjugates, which are the flavor of the season. So to start with, this is the present NCCN guideline. The slide is from Clinical Care Options, actually. So the first line therapy, approved therapy, we all are using endocrine therapy plus CDK4/6 inhibitors if possible in this group of patients. Second line therapy options, if the patient has not received a CDK4/6 inhibitor in first line, we have that option. Otherwise, the approved therapy is alpelisib, especially in the patients who have PIK3CA mutation. Now, what are the other options? There is the data on everolimus exemestane, which we have, the Bolero-2 data, which we had for a long time, but very difficult treatment to use. The single agent endocrine therapy, then chemotherapy, and the newer therapies of PARP inhibitors, pembrolizumab, the tumor agnostic approval in MSI high tumors, and the NTRK fusion based therapies. Similarly, in third line and beyond, abemaciclib has got an approval in third line because of the data which it has got, and only in patients who have not received CDK4/6 in first or second line, which is going to be a rarity in our present practice or future. With this background, let us see which are the drugs and the pathways which are there in this group of patients. So we have the aromatase inhibitors, we have the SERMs, the tamoxifen, torimifen, where tamoxifen is the drug which is used, the ER down-regulator fulvestrant, and the mTOR inhibitor, which is these are the drugs which we had since many years, and the entire landscape was changed with the arrival of the CDK4/6 inhibitors in the last few years. They have changed our practice in first line treatment of hormone positive metastatic breast cancer, which is HER2 negative. Now, what are the mechanisms of resistance to endocrine therapy? The cyclin D1 amplification, the activation of growth factor signaling pathways, and the dysregulation of ER pathways. The ESR1 activating mutations have a lot of interest, but we don't have very effective therapies yet. But I'm sure that with the way this group of breast cancer is progressing, we will soon have a lot of data with the ESR1 activating mutation being targeted. So I will start with the premenopausal group of patients, the mature data of MONALEESA 7 study, which established ribociclib with goserelin and tamoxifen in comparison with goserelin tamoxifen in this group of patients with a PFS improvement with an hazard ratio of 0.55. This is similar to the data in postmenopausal patients and led to the approval in premenopausal patients. And still, because of this large data, mostly if you have a premenopausal patient, there's a tendency to go for a ribociclib combination in this group of patients. We have data, this is the updated overall survival, and ribociclib somehow has got overall survival data. Sorry. So this is the overall survival data where there is improvement in the overall survival in this group of patients. So that led to the approval and most commonly used in this group of patients. Can we use palbociclib or other CDK4/6 inhibitors? We know that there is data, but this is an interesting study which I thought I should discuss. And this is in comparison with chemotherapy in this group of patients. You can look at it from both sides, whether we want to look at the benefits which is given by a combination of palbociclib, exemestane and leuprolide in this group of patients, or look at the other side, small study of single agent capecitabine. So there is an improvement with the combination 20.1 month versus 14.4. The hazard ratio is 0.65. We all want to use hormone therapy in hormone positive HER2 negative metastatic breast cancer patients. But if we balance the cost, and I think the cost is going to come down very soon, this discussion will become irrelevant. But still, single agent capecitabine gives a 14.4 months of PFS as a single agent even in this group of patients. Now let us come to the postmenopausal. The majority of data is in this group. We had these 3 trials. We were waiting for the mature overall survival data. I remember, or we all were part of discussions where we always used to discuss saying that this hazards which we are seeing in PFS should give a overall survival advantage. I can't remember any trial where with large number of patients, we have seen a hazard ratio of 0.58 in PFS, which has not resulted in an overall survival benefit. But that is what oncology teaches us. And we have the mature data of PALOMA-2, which I will be presenting in subsequent trials. So if you, in one line to summarize these 3 trials, very similar data, very similar outcome. And if you use a single agent AI, we get a PFS of around 15 months. If you use a combination with CDK4/6 inhibitors, it can become 25. The abemaciclib data is still not maturely published. So the mature data of overall survival which has come, again the ribociclib data, there is improvement, significant improvement in overall survival, which is statistically significant as well. And the 64-month overall survival, which was median survival in ribociclib plus letrozole arm, is very significant. 64 months is exceptionally good for a endocrine therapy versus 51 months in the placebo group. But when you see the palbociclib data, the overall survival 54 months in the palbociclib arm, the placebo almost similar to the ribociclib data. Time to chemotherapy, which was another endpoint, was significantly prolonged in the palbociclib arm. But to say that the overall survival data, when we have with ribociclib with mature data, palbociclib definitely has not given us the overall survival benefit. Now, when we see these, we should look in more detail into these studies. It is not fine to do cross-trial comparisons, which we all say, but with the palbociclib losing its getting into generic mode in the next year, we have to look at the data more carefully before we say that this drug is not going to give us benefit. The palbociclib actually had patients, most of the de novo metastatic breast cancer percentage was reasonably okay, but the disease-free interval from the first-line therapy or the adjuvant therapy less than 12 months was 22%. That is about 1/5 of the patients, or even 1/4 of the patients in palbociclib group, while in the ribociclib there was only 5%. So when you take the other group of patients, that is when you take the patients who had a DFI of more than 12 months, the median overall survival is exactly similar to what was in the ribociclib arm. So are we okay to look at it and say that, see, this drug works? It may give you the similar benefit if you carefully select the patient. That is something to be discussed, but definitely this is something to understand from this study. So now we have, in summary, about the first line and the second line combinations of CDK4/6 inhibitors in HER2 negative hormone positive group. The first line therapy data, the mature overall survival from palbociclib and ribociclib data has come. The ribociclib data gives a mature overall survival of 64 months. The palbociclib gave a mature overall survival of 54 months, which is not statistically significant. The abemaciclib data is still not published, but I hear that the data is showing around 67 months of overall survival. We will wait for the publication before we comment on that. Second line, there is no doubt about what is the best option. If we have a patient who has received only single agent aromatase inhibitor, then the combination with fulvestrant and CDK4/6 inhibitor, regardless of what is the combination, will give an additional benefit in PFS. Here also, if you see the hazard ratios for palbociclib in overall survival is not as much as the ribociclib and the abemaciclib data. So palbociclib data, either because of the trial population or because of some drug related thing, has not given us the expected overall survival data. Now, what are the mechanisms of resistance to CDK4/6 inhibitor? Though this is a nice cartoon which I have pulled out again from Clinical Care Options, we don't have excellent data on this, and we will wait for further more analysis to say that this is exactly why patients progress after CDK4/6 inhibitors, and this is the best way to go ahead with that. Now, beyond CDK4/6 inhibitors, is there a role of continuing after progression? This we have sometimes continued in our practice because of the patient support programs making the drug available. But the data, we have this study, interesting study called MAINTAIN, which has looked at a switch addition of ribociclib and switch endocrine therapy in patients who have received CDK4/6 inhibitor, which could be any CDK4/6 inhibitor in first line. And some interesting data that if you continue with the CDK4/6 inhibitor, you are actually doubling the PFS here. And this has led to all the other drugs, all the other CDK4/6 inhibitors now looking at these group of patients, which we all have in plenty, who have progressed on first line CDK4/6 inhibitor and AI combination. So the mTOR inhibitor pathway data, the data from Bolero trial, everybody knows. I think that was the previous CDK4/6 inhibitor kind of drug, but very difficult drug to use. But the lucky patients are the ones who actually tolerate everolimus well. We have data coming from temsirolimus and other mTOR inhibitors in combination with fulvestrant. One of the pathways which is not very much used these days because of the immense data which we get from the CDK4/6 inhibition. Now the other approved drug, the alpelisib drug, alpelisib with fulvestrant data, the SOLAR-1 study, which was published in NEJM in 2019. This looked at all patients who progressed with first-line therapy. Specifically, the primary endpoint was the PFS in the PIK3CA mutant cohort. And this was by tumor tissue. Mostly we are doing by liquid biopsy these days. So the primary endpoint in the trial met the primary endpoint. The median PFS was 11 months versus 5.7 months. Overall survival in the entire population is not statistically significant in this group. But when we take the PIK3CA mutant group, which is the area of interest, which I think is around 1/3 of the patients in this group, we can see that there was a prolongation of median overall survival by 14.4 months in this group of patients. So this led to the drug approval, and it's the standard of care now. Another difficult to use drug, specifically the hyperglycemia, is one of the difficult things to manage in Indian patients. We are suffering to manage the hyperglycemia in this group of patients. But if you are able to manage, it's a good drug to use, specifically in the PIK3 mutant cohort. Now, when we say that the side effects is difficult, we are looking at different PIK3CA mutation in PIK3CA drugs now, which are in pipeline. Now the PARP inhibitor data has come in all breast cancers, and hormone positive breast cancer group also. There is data of using PARP inhibitors. There is improvement in PFS as compared to chemotherapy. But do we have data as compared to the newer endocrine therapies? We don't have. So the recommendation, though there is approval in any line, the recommendation is not to use them in first or second line in patients who are ER positive and HER2 negative. So this is the algorithm. This is the algorithm which for a patient who has got a BRCA mutation, we can offer monotherapy from first line through third line, but mostly it is not preferred to use in the first line or second line. Can we combine the PIK3 inhibitor with CDK4/6 inhibitor and endocrine therapy? Definitely, this is like what we use in chemotherapy. When we have two effective drugs, can we use them both together? It will be interesting to see this data, but it is a tough combination to use. 56% of the patients had grade 3 neutropenia and 44% had grade 3 hyperglycemia, which will be challenging in our practice to use this combination. The investigational PIK3CA inhibitors are in trial. We will wait for further data before we discuss them. Then there is the other pathway, the AKT inhibitors, the capivasertib data, which the FACTION trial, which looked at fulvestrant plus capivasertib in ER positive breast cancer. As compared to placebo, there was an improvement in PFS, which was significant, and OS was also improved in this group of patients. Specifically, if you look at the pathway altered patients, there was, please don't ask me how you look at that pathway. I don't know. I tried to look at this paper. If somebody can help me with this data, I'd appreciate that. The pathway altered patients, there was an improvement, significant improvement in overall survival as well. So interesting data and interesting drug in this, which is making this group another possible treatment in this group of patients. There are phase 3 trials of capivasertib with fulvestrant and palbociclib in second line, and we will wait for the updated data of these studies. Now we look at the ESR1 mutations, which were which were discussed in detail initially as a choice for fulvestrant, and it is rare in primary tumors, but when you take the patients on progression, it is as much as 40%. So one of the reasonably we can say that one of the cause of endocrine resistance definitely ESR1 mutation. Will we have effective drug? We are waiting for that. We have many oral SERDs which have potentially active against ESR1 mutation, including the Y537S. Many of them, there are response rates which are reasonably interesting to go for further studies, but we will wait for the data. We should know that 60 to 70% of the patients in these studies have received prior CDK4/6 inhibitors and fulvestrant, and meaningful responses of disease control up to 40% in many of these in many of these trials. The phase 3 trial, we don't have.
You to conclude your session in 2 minutes.
I will do that. The phase 3 data is not yet ready, so we'll wait for that. Now the final session is on the antibody drug conjugate data, which has come. That is the trastuzumab deruxtecan has thrown everything up in the air in breast cancer metastatic. This includes hormone positive, HER2 negative or HER2 low patients. And we don't know whether this will change the complete landscape in these group of patients. We will wait. But similar data has come with other antibody drug conjugate, the sacituzumab govitecan and Dato-DXd. So these are not to be ignored, and we may find that there is a role of antibody drug conjugate in hormone positive HER2 negative breast cancer as well. I will not go into the detail of this study because these are early data and we have to conclude in 1 minute, is what I have been told. So this is my conclusion slide. So the key takeaway, the CDK4/6 inhibitors have demonstrated survival benefit and should be used in first line. There is no doubt about that. And for patients with BRCA mutation, the recommendation is to use a CDK4/6 inhibitor in first line and administer PARP inhibitor on progression. If there is a PIK3CA mutation, alpelisib is a second-line efficacy in post-CDK4/6 inhibitor as well is seen. The post-CDK4/6 progression is heterogeneous. Novel drug development is crucial. SERDs are in late phase development. We may see them getting approved in this group. The combination of SERDs with CDK4/6 inhibitor is another interesting way to look at. And the continuing CDK4/6 beyond progression, we need to further validate. We have studies which are looking at it. Antibody drug conjugates are here to stay and make this crowded field more interesting. That's all I have. Thanks for patient listening.
Thank you, sir. Thank you so much for such a wonderful talk. And next, we will move on. The session sponsored by Pfizer. And before that, I would request Dr. Rahul Sood, sir, to invite Dr. Lokesh, who has joined.
Yeah. Good evening, one and all. I would like to invite Dr. Lokesh, who has joined us. I believe he's chairing this session. Ekta?
Yes, sir. Yes, sir. For chairing
Yes.
the session.
Welcome, Dr. Lokesh, and the stage is all yours.
I think he's muted. So as we move further, the session is sponsored by our academic partner, Pfizer. And I would like to invite Dr. Roshni Das Gupta, who is consultant medical oncologist at HCG Hospital, Bangalore, and she's going to speak on palbociclib real-world evidence effectiveness data. Over to you.
Thank you so much. Good evening, everyone. Good evening, Dr. Rahul Sood, sir. I'll just share my screen if I'm allowed.
Yes, ma'am.
I hope it's visible.
Yes, ma'am.
So I think we will swiftly start and discuss regarding the treatment benefit of CDK4/6 inhibitors, especially keeping in mind the palbociclib data that has come up in ASCO 22, especially the overall survival data. So these are my disclaimers to begin with. We are very much aware of the CDK4/6 inhibitors benefit, which has shown survival benefits, especially in progression-free survival across all trials, across all CDK4/6 inhibitors that are currently available. And it is included as the recommended first line and as well as second line therapy in most of the guidelines, including NCCN-SO and ABC5. So this is a gist of the trials, and across all of them, we have seen PFS benefit, be it the Mona Lisa or the Paloma trial, and the overall survival benefit data, which has overall survival data that has come up. Mona Lisa and Monarch have been able to succeed to some extent. Monarch and Paloma in some of the trials have not been able to show overall survival benefit, and we will shortly discuss specifically regarding the Paloma trial. Now this is just an introduction regarding how CDK4/6 inhibition helps along with aromatase inhibitors in this ER/PR positive HER2 negative metastatic breast cancers. This particular spider diagram basically shows that abemaciclib is one of those drugs which is more non-specific when it comes to inhibition of the type of cyclin dependent kinases, whereas ribociclib is the minimum and palbociclib lies somewhere in between, and not very conclusive, but probably that is how their side effect profile is defined. Now, to the recent update, ASCO 2022, which showed the overall survival data for patients treated with palbociclib and letrozole versus placebo and letrozole in women with ER/PR positive HER2 negative advanced breast cancer, the Paloma 2 trial. So the background, I think we are all aware of. Palbociclib was the first CDK4/6 inhibitor approved for the treatment of this subgroup of patients in Paloma 1 trial in 2015, which was then followed by Paloma 2, which showed statistically significant and clinically meaningful improvement in the primary endpoint of PFS, confirming the findings of Paloma 1. The delta between the two group of patients with and without palbociclib was around 10 months, with a median PFS of 24.8 months in patients in whom palbociclib was used, 14.5 for the placebo group. So at the time of final analysis of PFS, the OS data was not mature, and the final OS analysis has been now performed. in November 2021 after a median follow-up of 90 months. So this was the basic background. Again, we are very much aware it was a 2:1 randomization. The primary endpoint was investigator-assessed PFS, while the OS was a secondary endpoint, along with response, safety, biomarkers, and patient-reported outcomes. It was further stratified based on the sites of metastasis, the disease-free interval, as well as prior neoadjuvant or adjuvant hormonal therapy. Now, coming to the primary endpoint, progression-free survival, this has been quite well established now that palbociclib arm had a PFS benefit over the placebo group by a delta of around 10 months, and it was statistically significant. And the updated analysis still stood the test for statistical significant benefit for using palbociclib along with letrozole. The baseline characteristic when was quite well matched between the two arms. Now, when the OS data was being studied, so this is what the Pfizer group, the scientific committee came up with as to, especially when they were trying to analyze why it did not reach statistical significance. And they found that there was a significant missing survival data, which was around 13% in the arm of patients receiving palbociclib and 21% who were on the placebo group. Now, the overall survival data in the intention treat population was numerically higher than that of the placebo arm when patients were given palbociclib. However, the hazard ratio, the confidence interval crossed the 1 mark, and the p-value was not significant. So when they further analyzed the subgroups and the missing, especially among the missing data group, there was a significant disproportion among the population with ECOG performance status, which we know who would perform well. But this group was actually disproportionately more missing in patients who were given placebo. The other subgroups like other ECOG performance status, disease-free interval, prior endocrine and prior chemotherapy, bone-only disease, these missing data were least disproportionate. Now, in the post hoc sensitivity analysis, which excluded the patients for the missing data, then after that also the OS somehow did not reach statistical significance, though it was numerically higher. So then they further analyzed statistically the PALOMA-1 and PALOMA-2. They combined the OS analysis, and among all patients, again, the OS did not reach a statistical significance. Only in subgroup with a disease-free interval of more than 12 months, which is a favorable subgroup, the patients reached a statistically significant OS benefit for who received palbociclib. So the post-study systemic therapies, when analyzed for OS, as we see in this particular table, that patients who had received placebo initially in the PALOMA-2 trial, they eventually went on and received CDK4/6 inhibitor, which probably would have contributed their increased overall survival and henceforth decreased the delta between the two subgroups, between the two arms. Time to chemotherapy. This was palbociclib did prove beneficial as compared to the placebo with letrozole arm, and hazard ratio was 0.73, so that was significant. And so this is something that I generally prefer not to do. It is a cross-trial comparison between PALOMA, MONARCH-3 and MONALEESA trial. They have all shown PFS benefit, but the pitch point that the PALOMA-2 trial tries to show is that they had a larger population of the poor prognostic subgroup, which was disease-free interval of less than 12 months. Whereas the survival benefit in MONARCH as well as MONALEESA-2 trial was actually driven by a population which was more favorable because their disease-free interval was more than 12 months. So in conclusion, PFS benefit was irrespective of whether it was a DFI, whether the patient had DFI of less than or more than 12 months. And the OS difference is affected by the disproportionate missing survival data in the PALOMA-2 trial. Now, what does it exactly mean? What does the missing survival data, how do they affect clinical trials? And it is said that typically, if there is a loss to follow-up of more than 20%, it poses a serious threat to validity of the data. And if it is more than 10%, it may pose to biases. So Palomar 2 was subjected to these kind of validity issues. Now, coming to clinical trial endpoint as to whether PFS should be a stronger point to reach to in this group of patients with ERPR positive or negative. This particular National Cancer Institute Breast Cancer Steering Committee have shown that PFS was one of the strongest endpoint for assessing benefit of different drugs in this particular subtype of breast cancers. Among the adverse events, it is very well known that palbociclib does cause neutropenia in majority of the patient. Almost 80% develop any grade neutropenia. However, the chances of infection and febrile neutropenia is comparable with that of the placebo arm. So to conclude, Palomar 2 met its primary endpoint. PFS benefit was seen across all subgroups. Overall response rate was seen in 55.3%, which was again 10% more than that of the placebo group, and it was statistically significant. There were no new safety signals. Quality of life was well maintained. However, though the OS reached a numerically higher number in palbociclib group as compared to the placebo, but it was not statistically significant. Now, the interpretation of OS data, however, is subject to a lot of questions because of the missing data. So Pfizer went ahead one more step and they started looking into the real world data. So this P-Reality X, it studied the real world data for first line therapy of palbociclib in patient as compared to only hormonal therapy. And they tried to balance the disproportionate, this was a retrospective study. So to get over the biases like missing data, confounding, misclassification, selection, and reporting, they took some steps which was known as inverse probability treatment weighing, as well as propensity score matching. In this particular statistical analysis, they have tried to match the baseline characteristic of the patient. Both these data were retrospective in nature. So if it's too busy slide, but more or less they could match the baseline characteristic of the different cohorts. And when they came out with the overall survival data after this balancing, statistical balancing, it actually reached statistical significance. Not only the overall population, but also in the subgroup analysis, it showed benefit. Most of the subgroups received benefit, and this data was on around 2,888 patients only from US. The PFS in real world data, again, as per Palomar 2 trial, they held the statistical significance benefit for palbociclib. Now, the strength of such real world data is that the sample size is quite large. It comprises of more than 3 million patients from 280 different community cancer centers, including academic centers. They have a good data base, large number of patient characteristics were assessed during this time. And the follow-up time was sufficient to obtain the PFS and OS estimates for both the treatment arms. The statistical techniques that have been used, the IPTWF and the PSM, it helped in balancing the patient baseline characteristic to prevent the bias as much as possible, because this was a retrospective study again, and there was lack of randomization. But again, that itself points out to the limitation of this real world data, because there is no randomization, and also we cannot determine the causal relationship. There have been some baseline patient characteristics, unobserved variables, which cannot be ascertained from these real world data. So to conclude, the P-Reality X real world study did show statistical significance of using palbociclib and aromatase inhibitor when it came to overall survival benefit in a heterogeneous population group. The evidence supports the use of palbociclib in combination with aromatase inhibitor in this subtype of patient. And this real world data was in fact, one of the driving forces for FDA approval of palbociclib in USA. To summarize, again, CDK4/6 inhibitors across all trials, they have been pivotal and they have changed our practice, where we have resorted to CDK4/6 inhibitors along with hormonal-based treatment in metastatic breast carcinoma. There's increased evidence available now from different randomized control trials for longer OS with CDK4/6 plus endocrine therapy. However, the difference in OS, in particularly Paloma 2 trial, was not statistically significant, which was counteracted by the data they presented from the real-world evidence. And according to the worldwide guidelines, we know that CDK4/6 inhibitors are now the standard of care in subtype patients with hormone receptor positive and HER2 negative advanced metastatic breast cancer. Thank you, and I'll conclude.
Thank you, ma'am. Thank you so much for such a lucid talk. And we still have 5 minutes to go. So any questions? We can take up any among the panelists. Any questions can be addressed.
Hi, Dr. Roshni.
Hi, sir.
Hi. So very interesting data. I think the premenopausal is a place where I think ribociclib was ruling the roost, and now with the young pearl data coming in, also, yeah. So you know, the biosimilars are also coming. The generic versions are also coming. So what is your practice in premenopausal? What is the drug of choice, CDK4/6 inhibitors? Because we've been using even palbociclib in the premenopausal because of the government institute and the availability of palbociclib. So what has been your experience in premenopausal?
Sir, in my experience, I have a few patients who are on palbociclib, and right now on the top of my mind, I can remember around 3 patients who have been on palbociclib for the last 18 to 24 months, and they are doing well. They have neutropenia, but it's never significant. They have never been admitted in the hospital. But specifically in premenopausal age group, there are 2 considerations. Again, we are usually driven by data. And given the MONALEESA-7 trial for ribociclib with a 6.6 years of follow-up, good follow-up data, overall survival benefits, especially de novo, no prior therapy, I think I would tend to use ribociclib more, honestly. And though palbociclib can be used in these patients, because again, neutropenia is not a very restrictive factor when it comes to premenopausal young patients.
Thank you.
Thank you. Thank you, doctor. And I think Dr. Rajat Bajaj sir has joined. Good evening, doctor. And we move on to the next session, which is sponsored by our academic partner, Novartis. And for this, I would like to invite Dr. Rajat Bajaj, who is Senior Consultant Medical Oncology for Fortis Hospital, Noida. And he's going to deliver his talk on getting real with ribociclib, bridging the RCT and RWE universe with evidence across 8,000 patients. Over to you, sir.
Good evening, everyone. Am I audible?
Yes, sir, you are audible, but the voice is not so clear.
Just is it better now?
Yes, sir.
Okay. Can I be allowed to share my screen?
Yes, sir, you can share it.
I think there's some issue.
So we can share it from our end if you permit, sir.
Please do that.
Yeah,
So,
Ankit, please share the screen.
yeah, by the time the slides are getting shared, I say hello to Dr. Rahul Sood and thank him for having me here and all the organizing team members. And I thank Novartis for this opportunity. It was very interesting that Dr. Roshni was talking about palbociclib, but the moment overall survival came in, that she said that she would like to give ribociclib, but probably CDK4/6 inhibitors, there has been a class effect, and even palbociclib, I would say, will do the job in premenopausal. Although of course the data is more for ribociclib, as we'll see in the next 10 to 15 minutes. Right. So the topic that has been given to me is getting real with ribociclib. That is, we are trying to bridge the RCT and the real world experience universe with evidence across more than 8,000 odd patients. Next slide, please. So when we are considering options for advanced breast cancer, when we are talking about be it hormone receptor positive, triple negative, or HER2 positive, as a medical oncologist, I'm sure all of the oncologists present in the meeting will agree that overall survival is the gold standard endpoint that we are looking at. This is what I was discussing when I was talking about PAL-based versus ribociclib a minute back, and it is touted as the most reliable cancer endpoint, overall survival, and when the studies can be conducted to adequately assess the survival, it is usually the preferred endpoint. What is it exactly defined as is something that all of us know: time from randomization until death from any cause, and it is measured in the intention to treat population. Next slide. When we say overall survival, we talk about CDK4/6 inhibitors in hormone receptor positive, HER2 negative advanced breast cancer patients. We all agree, and it is there on the screen right now, that out of the 3 available CDK4/6 inhibitors, that is palbociclib, ribociclib, and abemaciclib, ribociclib in all the 3 trials, which is MONALEESA-2, MONALEESA-3, and MONALEESA-7, respectively being in first line, second line, and MONALEESA-7 being in first line premenopausal patients, it has shown to have an improvement, significant improvement in the overall survival. And abemaciclib also has got the same in Monarch 2 data in the second line, but it does not have that. It's still pending in Monarch 3. Palbociclib does not have. We've already seen that in the talk by the previous speaker. Next slide, please. So when I say that patient has got an improvement in the overall survival, how much of an improvement is also something very important. So approximately by an year, and this is across the 3 trials and all the settings which I just mentioned. So when I talk about MONALEESA-2, it is Crixana along with AI in the first line postmenopausal ladies, where the delta is to the tune of 12.5 months with a hazard ratio of 0.76 with a p-value being significant. When we talk about MONALEESA-3, which is first line postmenopausal with fulvestrant, also having second line patients, the delta is to the tune of 15.8 months, although this was a heterogeneous population group, and we all know that. And if we talk about MONALEESA-7 against first line with premenopausal patients alone and with ovarian function suppression, it is about 11 months. So which means that certainly there is an increase, statistically significant increase in the overall survival, and it is across the endocrine partners and irrespective of the menopausal status, which gives us a lot of confidence as a medical oncologist or a clinician sitting in the OPDs to discuss this particular patients who are eligible for. So all these 3 data sets that we have already known since years now is randomized control trials. But all of us will agree that many a times we don't have such patients in our OPDs, and we have patients who are actually not having a very good performance status, patients who are probably having more of visceral metastasis, more of CNS metastasis. So how do we really deal with those patients? Should we have confidence in giving ribociclib even to those patients? Probably the answer is yes, and that yes comes from the real world experience that we have with Crixana. Next slide. And when I say real world experience, I'm talking about these 2 phase 3 studies, which is the complement study and the Ribana study. These studies are the real world evidence of ribociclib with their endocrine partners for the treatment of HR positive, HER2 negative advanced breast cancer. Next slide. So we'll be talking about these 2 one by one, the complement study and the Ribana study, first and the second. So complement study is a phase 3B international study of ribociclib plus letrozole as a first line therapy in men and women who have not received any prior endocrine therapy for HR positive, HER2 negative metastatic breast cancer. A total of 3,200 odd patients were included in this particular study, phase 3 study. Ribana is an ongoing prospective German study of real-world efficacy of ribociclib plus AI or fulvestrant compared with endocrine monotherapy, whatever endocrine therapy was taken along with ribociclib, or chemotherapy as a first-line treatment of patients of hormone receptor positive, HER2 negative advanced breast cancer. Again, good number of patients, 2,500 odd patients were selected. So a total of approximately 8,000 patients data set is what we are going to discuss in the coming slides. Next slide. So if you look at complement study, the study designs in the real world practice. So approximately 3,000 odd patients. Initially they were planned, and after that final enrollment was of 3,200 patients. Men and women, any menopausal status, hormone receptor positive, HER2 negative, advanced breast cancer, no prior endocrine therapy for advanced breast cancer, and very importantly, a DFI of more than 12 months from the completion of adjuvant endocrine therapy, if at all it was given, less than equal to 1 line of chemotherapy for advanced breast cancer, and a good performance status, certainly less than equal to 2. They had patients who were ECOG PS0 or ECOG PS1 or 2. CNS metastasis was allowed if it was stable for more than 4 weeks. And ribociclib plus letrozole was given as the intended treatment, with the primary endpoint being safety and tolerability, and the secondary endpoints being time to tumor progression, overall response rates, clinical benefit rate, and the patient reported outcomes, which is always a very important part of any real world experience that we are looking at. If we talk about Ribana was 3,000 odd patients. Initially planned enrollment of 2,500 odd, where I said in the beginning that these patients were selected. They were given chemotherapy, they were given endocrine therapy, and some of them they were given endocrine therapy alone, and the rest of them they were given Crixana plus the intended endocrine therapy, with the eligibility criteria being almost the same. Next slide, please. Now, if we talk about the clinical evidence from complement study, next slide. So very importantly, one has to understand that 3,200 odd patients, there were about 112 patients with a PS of 2. There were about 1,900 patients with a visceral metastasis. There were patients who had received prior chemotherapy, with only one chemotherapy being allowed prior to the selection of endocrine therapy, which was about 200 odd patients, and 50 odd patients had CNS metastasis. And so it includes a diverse, large population of subgroups which are more representative of a real world practice. And they included patients who were treated with prior chemotherapy for advanced disease, ECOG PS of 2, stable CNS metastasis, premenopausal status, and diverse age and race. Next slide. So let us see how things fared in these particular subgroup of patients when they were given Crixana plus letrozole. Next slide, please. Like I said, that safety profile was the first intended primary endpoint which was supposed to be seen. So very interestingly, it was found out that these patients who were given Crixana plus letrozole had treatment-related adverse events, but most of them, they were grade 1 and 2. So like it is very clearly mentioned that there were about 65% patients who had treatment-related grade 3 or more adverse events. The serious adverse events, they were even lesser, just about 5 to 6% with treatment-related adverse events. The fatal ones were less than 1%. Treatment, the adverse events leading to treatment discontinuation also were just about 6 to 7%. So the side effects were there, but they were manageable, they were predictable. When we say predictable, it means that they were in line with the randomized control trial, and the events reduced with a prolonged exposure is something which is very important. We as medical oncologists want that patient should have a good quality of life when we are treating a stage 4 patient. And here it did happen that way, that with the continued treatment, the possibility of a transaminitis or a QT prolongation or a neutropenia, it kept on decreasing. We do understand and know that QT prolongation is seen in the initial 15 to 20 days, can last for about 2 months or so, and after that it is not seen. Same was the case here. Same is the case with neutropenia. So very heartwarming to know that the adverse events, they reduced over a period of time when the Crixana was continued. Next slide. If you look at the efficacy, that also is very important. This is the secondary endpoint that we're talking about. The median time to tumor progression, 27 months. If you look at the exploratory analysis, 26.7 months, so nearly the same. If you look at the percentage event-free probability estimates as the time moved on from 12 months to 24 months to 33 months, even at 33 months, the event-free probability was 40% nearly. So which is quite a good thing for us to see as a clinician. Next slide. Now, if we next slide, please. Now, if you look at the response rates, again, one of the secondary endpoints, the response rates were both with patients which was intention to treat or patients with a measurable disease about 70%. And this again is mirroring what was seen in the randomized control trials. Next slide. And one has to remember that we are talking about all comers. All comers means that patients here had a PS of 1 to 2. There were patients who had CNS metastasis. There were patients, about 70%, who had visceral metastasis. Very commonly, we see patients in our OPD where we have CNS metastasis, although hormone receptor positive patients will have a less compared to triple negative and HER2 positive, but we do come across this subset of patients, and one tends to really ponder upon whether we should give Crixana or not. So this study had 50 patients approximately with CNS metastasis. There have been other studies where abemaciclib has abemaciclib studies have had patients with CNS metastasis, where we have seen a intracranial clinical benefit rate of about 25%, especially with Monarch 2 study. Next slide. So what did we really see in the CNS metastasis group? In the CNS metastasis group also, the time to tumor progression was improved as with Crixana plus letrozole. And if you see this Kaplan-Meier curve, all patients versus patients with CNS metastasis, the time to tumor progression was not reached for patients with CNS metastasis till the time this study was published. And if you look at the other bad prognostic subgroups, be it the prior chemotherapy or the ECOG PS of 2, there also the time to tumor progression has been to the tune of 18 to 19 months. Patients who have got visceral metastasis with prior chemotherapy, there also it was approximately 12 to 13 months, and visceral metastasis plus a ECOG PS of 2, they're also about 18 months. So of course, not as good as it has been in the intention to treat population, but still it is something which is a confidence building in the sense that this drug in the real world scenario also is working in patients where they have not been a very good subset of patients, so to say. Next slide. And of course, very importantly, what has been the patient reported outcomes, the fact the emotional and functional well-being scores. Here also, the scores were seen, and it was implied that the quality of life was maintained while these patients were on treatment with Crixana and letrozole. Next slide. Now, from complement, talking about Ribana, which is a clinical evidence of a German ongoing prospective non-interventional study. Next slide. Where, like I said in the beginning, about 2,500 odd patients were selected. They were given chemotherapy, they were given endocrine monotherapy, and they were given ribociclib plus that endocrine monotherapy. The median age was nearly the same in all the three arms. There were minimum number of patients for chemotherapy, just about 145 out of 2,500, which is understandable because CDK4/6 inhibitors has been the go-to drug now. And if you talk about the menopausal status, that has also been nearly the same in all the three arms. They were mostly patients who were having post-menopausal status. There were good number of patients who had more than one PS, that the ECOG PS, which was more than one in about 50 odd or maybe at times 60% also in the endocrine monotherapy. Good number of patients who had CNS and liver metastasis. In the chemotherapy arm, there were about 65% patients where there was CNS and liver metastasis. So that is why chemotherapy was started, although that point is also debatable. It overall summarizes this baseline patient characteristics, that there were quite a few a number of patients which we would not really term as good patients, so to say, coming to our OPDs. Next slide. So if you look at this data set of the progression-free survival from the full analysis set, we look at the progression-free survival, and we see that the patients who were on ribociclib plus the endocrine therapy, they did the best in terms of unadjusted median PFS as compared to endocrine therapy or chemotherapy. It was 31 months versus 25 months versus 15 months. So the maximum PFS with the combination of Crixana plus endocrine therapy was achieved, which again is mirroring almost what has been seen in the RCTs. Next slide. If you look at the safety profile also was reassuring. The QTC prolongation was seen in very few number of patients, grade 3 and 4 in less than 1% in the ribociclib arm. The transaminitis also was just 1 to 2%, increased blood bilirubin levels 0.2%. So the most frequently treatment emergent adverse events in the ribo plus endocrine therapy arm were neutropenia, about 25% of them, very few febrile neutropenia patients, nausea and fatigue, which all of us know does happen with Crixana. Next slide. If you look at the outcomes reported in the phase 3 trials, which are achievable in the real world practice, this is the slide where on the left hand side is the real world scenario and right hand side is the RCTs. We see that
Dr. Rajat Bajaj, sir, there is some disturbance in your voice.
With evidence of complement and Ribana was achieved RCT that we know. If we talk about the dose adjustment, okay, just a minute. Am I audible?
Yes, sir,
Hello?
but in between the connectivity, I think your bandwidth is quite low. That's why it's happening.
Okay, I'll try to. So the discontinuations due to AEs were a little higher than what it was in next slide. Am I audible? Can I have the next slide, please? Yeah, so the guidelines, all the guidelines also recommend ribociclib, be it NCCN or the ESMO guidelines. It says that ribociclib, along with the endocrine partner, be it in the first line or the second line, is the preferred option along with the other CDK4/6 inhibitors. But NCCN discussion very clearly mentions that the only overall survival which has been seen is with ribociclib studies. If we talk about the ESMO MCBS score, a score of 4 has been achieved in Mona Lisa 2 and 3, and a score of 5 in Mona Lisa 7. And ribociclib is the only CDK4/6 inhibitor to do that. Next slide. And just last one slide on how the CDK4/6 inhibitors are different, even if we talk about the pharmacokinetics. Next slide. So we do know that we're talking about CDK4/6 inhibitors, but palbociclib is a inhibition of CDK4 and 6 equally, whereas ribociclib inhibits CDK4 preferentially compared to CDK6. And that is why it is more selective in its approach, because CDK4 is what is expressed more in the breast cancer cells. If we talk about the off-target inhibition, abemaciclib has got off-target inhibition of inhibiting CDK9 as well, because of which it has got diarrhea as its adverse event profile, which is not seen with Crixana. Next slide. And ribociclib also exhibits higher selectivity for CDK4 and more drug available to penetrate and act on the tumor cells. If we see that the preferential inhibition of CDK4 versus 6 in ribociclib is to the tune of into 8 times, where it is only the baseline of 1 with Palbase, and the free drug concentration is also highest with Crixana. Next slide. So to summarize, Crixana, it recommends early usage of CDK4/6 inhibitors for patients of HR positive, HER2 negative ABC, the only CDK4/6 inhibitor to have the longest yet median OS of in excess of 60 months, improves the OS across the line of therapy, has got the satisfactory ESMO MCBS score of 4 and 5. It has got similar efficacy and safety in all the real world cases which we discussed. It has got good efficacy in the subgroups of CNS Mets, visceral Mets, chemo-treated and ECOG PS of 2 patients as well. and it has got a favorable pharmacokinetic profile as well. So with this, I thank the organizers once again for the opportunity. Back to the organizers. Thank you.
Thank you, sir. Thank you for the excellent talk. And any questions from the panelist side or attendee side can be addressed by the doctor, because we have time. Dr. Bharat has joined. Good evening, doctor.
Good evening. Am I audible?
Yes, sir. You're audible, you're visible. So
Thank you.
if there are no questions, then we'll move forward.
Yes.
Yes, sir. Dr. Rahul Sood, sir, should we move forward?
Please do, please. And hello, Dr. Bharat.
Hello, Dr. Thank you very much, for inviting me for this evening's wonderful discussion. So I'm supposed to, speak about advanced HER2 positive breast cancer. Next slide, please. So when we look at HER2 positive agents, I have just, gone through what has happened in the last 2 decades, really, from 2001 to till around 2022 in the field of anti-HER2 agents. Next slide, please. So when we look at historically, Denis Lemon published his first paper on trastuzumab, which was trastuzumab with chemotherapy. Actually, that trial had patients who had trastuzumab concurrent with anthracyclines and patients who had trastuzumab with taxanes. And this was one of the first studies. And we always talk about, whether overall survival has been improved when we sort of incorporate new drugs into clinical practice. And this trial actually showed an overall survival improvement, which was significant. And this established trastuzumab as the standard of care along with chemotherapy in HER2 positive breast cancer. Next slide. But it was not just trastuzumab. Subsequently, there was also a trial which looked at capecitabine and lapatinib in second line in patients who have already received trastuzumab. And this trial also showed a significant survival advantage for patients who had received lapatinib in the second line. So next slide, please. So we actually had established both trastuzumab in the first line and lapatinib in the second line as standard of care in HER2 positive breast cancers in the early 2000s. Next slide, please. But chemotherapy was not the only trialed partner. There is always a triple positive, that is both hormone positive and HER2 positive disease, whether to give in hormone partner along with trastuzumab was also trialed, and hormones also partnering with trastuzumab showed benefit over giving hormones alone when patients had both hormone receptor positive and HER2 positive. Next slide. And this was true for both lapatinib and trastuzumab, where anastrozole was trialed along with trastuzumab and showed superiority over anastrozole alone. And when letrozole was trialed along with lapatinib, there was improvement in the progression-free survival, significant improvement in the progression-free survival when letrozole plus lapatinib was used over letrozole alone. Next slide, please. So at the end of around 2000s, trastuzumab was established as standard of care in first line with a non-anthracycline chemotherapy. Single agent trastuzumab bar AI plus trastuzumab or AI plus lapatinib could be used in selected patients when you did not want to use chemotherapy for whatever reason, performance status, cardiac issues, or lapatinib plus capecitabine was better than capecitabine alone in patients who had received prior trastuzumab as second line therapy in metastatic breast cancer. Next slide, please. So then we came to the second wave of agents, which was TDM1 and pertuzumab. Of course, when we talk of TDM1, the Cleopatra is the most, next slide, please. The Cleopatra is the most important study. Next slide, please. So the Cleopatra looked at trastuzumab plus pertuzumab in HER2 positive patients. And this actually changed the standard of care from trastuzumab alone to trastuzumab plus pertuzumab. Now, next slide, please. The next slide, please. There was a significant overall survival advantage with a good separation of the curves, early separation of curves with a hazard ratio of 0.68, which was significant, which actually established trastuzumab plus pertuzumab plus docetaxel, which was used in the Cleopatra as the standard of care for patients with metastatic breast cancer in the upfront setting, in the first line setting. Next line, please. Of course, the trial also showed progression-free survival benefit. Now, what happened to TDM1 in the first line? Next slide, please. Next slide. TDM1 was trialed in the Marianne study, and this study actually addressed many questions, but maybe not all the questions. Anyhow, this trial had arms of trastuzumab plus TDM1, TDM1 alone, or chemotherapy plus trastuzumab, and this trial did not actually show any major survival advantage between the three arms. And so TDM1 as first line in combination either with trastuzumab or as a single agent did not actually come into practice. It may not be, this trial was designed for superiority, but it is not superior. Whether it is equivalent or inferior is a matter of debate. But anyhow, use of TDM1 alone or in combination with pertuzumab was not superior to trastuzumab plus a taxane in the first line. And what about TDM1 in the second line? Next slide, please. There were two slides, next slide, please. Next slide, please. So there were two trials that looked at TDM1 in the second line. The previous slide, please. The two slides which looked at TDM1 in second line, that is the Emilia and the Theresa. The Emilia randomized TDM1 to lapatinib and capecitabine. Remember that lapatinib plus capecitabine had been established as the standard second line therapy. And the Theresa looked at TDM1 against physician choice, because many times physician choice is more what is practiced in the community. And TDM1 in both the trials showed an overall survival advantage over lapatinib plus capecitabine, which is considered the standard second line, or over physician choice. There were also, of course, chemotherapy free regimes which came in, to look at trastuzumab plus pertuzumab. Which also, but they were phase 2 trials and which did show advantage over hormones alone or paclitaxel plus when you used trastuzumab plus pertuzumab, but these have not caught on as the standard of care, and we still continue to use chemotherapy plus trastuzumab plus pertuzumab in the first line and TDM1 in the second line. So next slide, please. So at the end of TDM1 and trastuzumab plus pertuzumab, the combination trials, which I would say post second wave of anti-HER2 new agents, taxane plus trastuzumab plus pertuzumab became standard of care. Any taxane is now used, although docetaxel was a drug that was used in the Cleopatra. AI plus trastuzumab plus pertuzumab, a chemo-free regime, may also be used if the patient is unfit or unwilling for chemotherapy. TDM1 does not show advantage in the first line. However, TDM1 is established as standard of care in the second line after exposure to trastuzumab, and it is better than capecitabine plus lapatinib or physician choice. And lapatinib actually after the second wave moved down to third line and beyond. Next slide, please. Next slide, please. So then we are coming to the third wave of agents, which included neratinib, margetuximab, trastuzumab deruxtecan, tucatinib, and trastuzumab duocarmazine. The Destiny trial, which looked at trastuzumab deruxtecan versus TDM1 in the second line, because TDM1 is now the standard second line therapy. It randomized in a 1:1 fashion between TDM1 and trastuzumab deruxtecan. Primary endpoint was progression-free survival. And next slide, please. The trial was positive for its primary endpoint, which was progression-free survival, with a median PFS which was not reached in the trastuzumab deruxtecan arm versus 6.8 months in the TDM1 arm, and the hazard was very good, a hazard ratio of 0.28. Trastuzumab deruxtecan seems to be really doing much better, at least in terms of PFS in the second line over TDM1. Next slide, please. And in the subgroup analysis of the forest plot, trastuzumab deruxtecan seems to be doing well across all groups in the hormone receptor positive, post-pertuzumab, in patients with visceral disease with multiple prior lines, and with stable patients on bone metastasis. Next slide, please. The overall survival, however, does not show the same magnitude of improvement that we saw with in the progression-free survival, but still the overall survival is also significantly improved with a hazard ratio of 0.56, which was significant. And it did not specify the cross the pre-specified boundary, which is important. So trastuzumab deruxtecan, at least in the second line, seems to be better than the TDM1. Next slide, please. Then we come to oral agents, agents that are not yet fully available in India. Tucatinib, which was trialed with capecitabine and lapatinib, capecitabine and trastuzumab in a randomized phase 2 manner. Next slide, please, which shows a good PFS advantage. Next slide, please. And an OS advantage as well. However, this is a phase 2 trial. The numbers are not very high. Next slide, please. The most important take home from this HER2-CLIMB study with tucatinib is that the CNS penetration of the drug is very significant, and there is a very good overall survival advantage, at least for patients who have progressed with brain metastasis. Next slide, please. So in patients who had brain metastasis, it shows a very, very significant improvement when combined with trastuzumab and capecitabine. Next slide, please. The next drug that we need to look at in this arena is the neratinib, which was trialed in the NALA trial. And this trial had neratinib plus capecitabine versus lapatinib plus capecitabine. Now, lapatinib plus capecitabine, at least at the time of starting these trials, were standard of care in the second line. And the co-primary endpoints were OS, overall survival, and progression-free survival. Next slide, please. The trial met its primary endpoint of progression-free survival, but did not meet its co-primary endpoint of overall survival. The overall survival was not significantly improved. The PFS was, of course, significantly improved. Next slide, please. The next drug that was looked at in the same setting, that is the second line setting, is margetuximab. Again, margetuximab was trialed against trastuzumab plus chemotherapy. And this trial also did not really show much improvement. So the margetuximab trial, in spite of much fanfare, did not show much of an improvement in the PFS or OS. And so it never really caught on as, standard of care, even in second, third, or subsequent lines of therapy. Next slide, please. Another agent that has been looked at is trastuzumab duocarmazine. This has been trialed in a phase 3 trial against physician's choice. Again, 2:1 randomization. This is for patients who have had metastatic disease, more than 2 lines of therapy for prior disease, and treated brain metastasis were also allowed. Next slide. The trial met its primary endpoint of progression-free survival with a progression-free survival of 7 months versus 4.9 months favoring the trastuzumab duocarmazine. We still wait for the overall survival reports. Next slide, please. Pyrotinib is another agent along with capecitabine, good CNS penetration. Again, trialed in subsequent lines and shows a good PFS advantage of 11 months versus 4 months. However, again, we have to wait for larger data with this drug as well as overall survival advantage. Next trial, please. Next slide, please. So, one important problem with the HER2/neu positive breast cancer is brain metastasis. They have a higher predilection, especially when we use agents that do not cross blood-brain barrier. Next slide, please. So I'll go through the last 4 slides fairly quickly. Patricia looked at pertuzumab with high-dose trastuzumab, that is 6 milligram per kg every week, not every 3 weeks, and showed some amount of improvement. Next slide. Again, the DESTINY-3 subgroup analysis of trastuzumab deruxtecan showed a very good advantage of CNS penetration, and the DESTINY-3, the same trial that showed an advantage over TDM1, also has very specific CNS activity and shows significant activity in patients with brain metastasis. Both neratinib and tucatinib, these are the trials, HER2CLIMB and the NALA trial, showed that these agents, neratinib and tucatinib, do have good CNS penetration. Next slide, please. So where do we go from here? We go from here for combinations of these drugs with other agents, because taxanes, we know we use up the taxanes in the first line. So whether to use vinorelbine in the subsequent line. Usage of afatinib, which also has got HER2 inhibition along with TDM1, and usage of immunotherapy in selected patients. These are the way forward. So next slide, please. So post third wave of agents, trastuzumab deruxtecan seems to be offering an advantage over TDM1 in subsequent lines, that is post exposure to taxane and trastuzumab. Newer agents like neratinib and tucatinib may be useful, especially in the third line and subsequent lines. It is also useful in patients who have got brain metastasis. Next slide, please, which is also my last slide. So, therapy, DESTINY accruing, and I think many people who are there in today's discussion are also part of DESTINY-9. So this will tell us whether trastuzumab deruxtecan will now move from second line to first line, and there may be another change in the way that we look at advanced HER2/neu positive breast cancer. Thank you very much.
So thank you so very much, Dr. Bharat Raghavan, for such an brilliant and exciting talk. I think we have some time. So can I request maybe Dr. Sood sir or anyone, Dr. Chetan sir, Dr. Poonam ma'am, if you have some questions, we have still 3-4 minutes to go. I think Dr. Sood sir is absolutely ready to throw some question. Over to you, Dr. Rahul Sood sir.
I was actually not ready to throw a question. I wanted to first compliment Dr. Bharat for just getting us through the entire gamut, starting from the early 2000s to now what we are sitting. And the waves were reminding us of the COVID waves. Hopefully, we don't get one post Diwali the way we are roaming around without masks. So wonderful, wonderful presentation. That's all I wanted to say.
Okay, great. So any words, Dr. Poonam Patil ma'am, any words from your side? You want to ask some questions? Dr. Poonam ma'am, yeah, good evening.
Yeah, no, it was really a great presentation. Bharat, you really took us through literally the journey of the patient of HER2 positive breast cancer from the history to the present. And have you had any experience with tucatinib or trastuzumab deruxtecan?
No, ma'am, not really. I have seen a patient who was on trastuzumab deruxtecan trial who came for a follow-up. Patient was on a trial on some other center in Bangalore, actually. They should come for some, questions, and I actually went through the file because it was interesting. And I did find that, the responses were extremely good. She was on the trastuzumab versus TDM1 trial, I think. I'm not very sure which DESTINY trial, but I think one was accruing in India, and she had an excellent response. But the thing is, I don't know whether she was on the trastuzumab deruxtecan or the TDM1 arm. Anyhow, I assume because
It
it's
was a
blind
blind trial. Yeah.
Okay. So I didn't know, but I mean, she had quite a lot of visceral disease, bone disease, and she was in CR when I saw her.
That's
In the second
amazing
line.
how this anti-HER2 agents have transformed the entire landscape of HER2 positive disease from being the worst type to probably coming towards best type.
Right. So thank you so much, Dr. Bharat sir, once again for such a marvelous talk and a discussion. We move forward, and of course, this is the academic partners, Roche, and it's a pleasure to welcome Dr. Devrat Arya. He's the Director of Medical Oncology, Max Hospital, Saket. We agree, sir, Delhi is absolutely bad as far as traffic is concerned. But thank you so much for making for your talk. And Dr. Devrat Arya is going to take us about again transform the journey for your HER2 positive breast cancer patient. So good evening, Dr. Devrat sir. Thank you so much for joining. I think everyone is eager to listen to you. Can we have the slides, please? Can someone run the slides?
Yeah, good evening. So it's been 2 hours that I've been on the road. For some reason, I'm getting reminded of Mumbai, where I have substantial family. So I think we just heard a wonderful talk by Dr. Bharat, talking about newer drugs which are there for the HER2 positive patients. And now, over the next few slides, I'm going to talk about your formulation and your way of administering some of these drugs. So, thank you, Roche, for the slide set, and this is our sponsored session. So over the next slides, just want to tell how the journey of HER2 positive breast cancer patient has been transformed with the advent of this newer formulation that we refer to as Phesgo. Next slide, please. So we know that Perjeta and Herceptin has transformed the treatment landscape. It has now become the standard of care. The first data came in the metastatic setting. That was the Cleopatra study, where when Perjeta was added to chemotherapy and Herceptin, it not only improved the median PFS by about 6 months, it actually improved the median OS by nearly 16 months. Thereafter, we had the adjuvant study, the affinity trial, where the addition of pertuzumab to trastuzumab and chemotherapy reduced the risk of recurrence by about 23%. And this was significant, even clinically meaningfully, improvement was seen in the node positive early breast cancer, where the risk of recurrence was reduced by up to 28%. And thereafter, it was no wonder that the drug was tried in the neoadjuvant space as well for early breast cancer at high risk of recurrence. The first study that looked at it was the NEOSPHERE study, where it was realized that when pertuzumab was added to trastuzumab and Herceptin, the PAT-CR rates on an average subsequently a number of studies which have actually, sort of confirmed the findings from these trials. And we know that Perjeta with Herceptin plus chemotherapy is now approved and recognized by international guidelines as patients. Next slide, please. Now, when you talk about the setting of treatment, particularly for early breast cancer, generally for the locally advanced breast cancer, I know the definition for a resectable LABC may differ from one institution to the other in terms of being referred to the medical oncologist, but broadly a node positive, HER2 positive early breast cancer or a larger primary, typically in my institute, any primary which is more than 3 centimeter, even if it's node negative and HER2 positive, would perhaps be referred for neoadjuvant setting. And we know that for these patients who do achieve a PAT-CR, the standard of care is continuation of trastuzumab and pertuzumab, whereas those who have a residual disease would be offered the option of TDM1. And similarly, for an early breast cancer, which has been a patient has been operated upfront, particularly in a node positive setting, most clinicians would be very keen to offer the option of adding pertuzumab to the adjuvant regimen. Whereas for the smaller tumors or a node negative tumor, a trastuzumab based chemotherapy regimen would perhaps still be the acceptable option. Next slide, please. So we know IV infusion of pertuzumab and trastuzumab has been well established, but there are challenges. There are long infusion time, and this can potentially lead to congestion at clinics and hospital. The challenge of improving resource utilization is there. The IV preparation time is much longer, and you requires a lot of associated resources. We know for most patients who are on IV anti-Hertinu agent, be it trastuzumab alone, most of these patients, most of these patients would require an indwelling venous access, and which is amenable to a risk of infection, thrombosis, and discomfort. And then lastly, there's the challenge of venous access in some patients, especially where you don't have a central line, where establishing venous access is going to be an issue. Next slide, please. So Phesgo is the first formulation which actually combines two monoclonal antibodies. So we've had the subcutaneous trastuzumab, which unfortunately was never available in India, although we all had some patients who received treatment in the US and had the SC trastuzumab. But Phesgo is unique in its way to combine both pertuzumab and trastuzumab in a single vial. So it contains the same antibodies as approved for IV pertuzumab and trastuzumab. It contains recombinant human hyaluronidase, which enables subcutaneous administration of high volumes. And we know that Phesgo loading dose is about 15 ml and the maintenance dose is about 10. And it's a ready-to-use fixed dose formulation. So it's a ready-to-use drug which has a short administration time of 5 to 8 minutes, which means that the resource utilization is much better optimized with this formulation compared to the IV formulation. Next slide, please. Can I request everybody in the background to be on mute, please? Tarunji, I think it's you. Can you please be on mute? Yep, thank you very much. So how does pertuzumab and trastuzumab act? We know how trastuzumab and pertuzumab act, and I'll not go into much details. But what's important here is hyaluronidase. Now it's an endoglycosidase. It is used to increase dispersion and absorption of the co-administered drug when administered subcutaneously. So it allows subcutaneous delivery of a larger drug volume. B, it improves the permeability of the subcutaneous tissue. And C, the effects of hyaluronidase in terms of improving the permeability are reversible and usually typically reverse in 24 to 48 hours. Next slide, please. So going into greater details. Next slide, please. Yeah. So going into greater detail, what this injection does is, in the subcute layer of the skin, there is a matrix of hyaluronan fibers along with collagen, which typically would limit the SC administration volumes to less than 1 ml. But when this recombinant hyaluronidase is added, it leads to a temporary local degradation of hyaluronan at the injection site without making any other change to the macromolecules, which include collagen and elastin. And this degradation is it will lead to a temporary increase in the local subcutaneous dispersion area, enabling a larger volume of fluids to be administered. So the architecture of the skin would be reformed within 1 to 2 days due to rapid clearance of the agent, and therefore it's one of the key factors why a larger volume of Phesgo can be administered. Despite typically when we see a subcutaneous injection, anything more than a ml is difficult now. What you see on the slide on the left side, next slide, please. What you see on the slide on the left side is a subcutaneous preparation without the recombinant hyaluronidase, and you can see clearly that immediately post infusion there's a swelling over there. But when you have the chemical compound added to the subcutaneous formulation, the swelling is minimal, as you can see on the right side of the slide. Next slide, please. So this is about, whether or not one is able to administer a larger volume or not. The second and the more important question is, does the pertuzumab, trastuzumab fixed dose combination, that is Phesgo, have the same pharmacokinetics, efficacy, and safety as the IV pertuzumab and trastuzumab? Next slide, please. So this was obviously a very important question in the Phesgo clinical development program. So obviously, the first step was finding and confirming the dose of the subcutaneous preparation, and which was basically a study called B030185. It was a phase 1B study in healthy human volunteers and also in early breast cancer. And then based on the recommended doses, they found out that the recommended loading dose of Phesgo contained 1200 mg of pertuzumab and 600 mg of trastuzumab, whereas the maintenance dose could have 600 mg of each of pertuzumab and trastuzumab. And then there was the subsequent pharmacokinetic efficacy/safety study, which was the Federica study, which was a phase 3 study in early breast cancer. It was actually an ongoing study. And then we also had the France SCA study, which is a phase 2 study, which is again an ongoing study, but we have had some primary results from both of these studies. Next slide, please. So the BO 30185 study was the dose finding study with different cohorts where patients received Perjeta IV and SC at different formulations. And then once the ideal formulation found, they also repeated that in phase 2, in a phase 2 part, in the part 2 in the patients with early breast cancer. Next slide, please. And the key findings was that the loading dose in the subcutaneous formulation for pertuzumab needed to be 1200 mg, and the maintenance dose could be 600 mg. And at that level, the pharmacokinetic data in the healthy male volunteers and patients with EBC resulted in an equivalent serum exposure for the subcu formulation compared to the IV formulation. And remember, this is the subcu dose of trastuzumab is very similar to the subcu dose of the subcu dose of trastuzumab in Phesgo is very similar to the subcu dose that we use for the standard trastuzumab. And also in terms of safety, there were no new safety signals, and the pharmacokinetic observation from this study led to further development. Next slide, please. So this led to the Frederica study, which was a phase 3 non-inferiority study assessing the pharmacokinetics, efficacy, and safety of the Phesgo versus IV trastuzumab, pertuzumab. Patients who are enrolled were having an operable or locally advanced, or inflammatory HER2-positive breast cancer, and then they were randomized to the standard chemotherapy with either the IV trastuzumab, pertuzumab, or the subcutaneous trastuzumab, pertuzumab, and then they underwent a surgery, and then they continued the corresponding IV or subcutaneous maintenance trastuzumab, pertuzumab, and the primary endpoint was the non-inferiority of cycle 7 pre-dose serum C trough concentration, and then obviously the other secondary endpoints were there as well. Next slide, please. So what was found was that the clearly the pharmacokinetic parameters are important, and so you need to look at C trough, you need to look at Cmax, and so you need to look at AUC. And clearly with the subcu formulation, there was an increase initially, the time period needed for increase in the serum concentration. But next slide, please. What was eventually found out was that in terms of previous slide, please. So in terms of pharmacokinetic availability, the findings were very similar. And when you look at the clinical efficacy, and this could be compared with the total pathological complete response rates. With the blue curve, the blue bar, which is the Phesgo bar, clearly there were no differences in the total pathological complete response rates for the IV versus the subcu formulation. The secondary, the C trough concentration was similar, and clearly in terms of clinical efficacy, not only the pharmacokinetics were similar, the clinical efficacy were also similar. Next slide, please. So what about safety? The safety profile for subcu formulation was comparable to IV. Hardly any difference between the two in terms of overall adverse events and grade 3 adverse events, and discontinuation rates as well. Next slide, please. And when you look at the common adverse events, they were also balanced in both the arms, and they were very consistent with what we have come to understand from the various clinical studies of the IV formulation. Next slide, please. And when you look at adverse events of clinical interest, so we know pertuzumab will have some incidence of diarrhea. We also are very interested in cardiac dysfunction, anaphylaxis, and other rare side effects like ILD. And when you look at the performance of the two bars, the red and the blue, so the IV versus the subcu, very similar incidence of these common adverse events. Next slide, please.
Ankit, can you go to the next slide? Yeah.
Yeah, so even when you talk about cardiac safety, there was no meaningful difference in the cardiac safety between the two arms. So very similar, declines in left ventricular ejection fraction and secondary cardiac events in both the arms. Next slide, please. So clearly, this study showed that the sub-Q preparation was non-inferior to the IV preparation in terms of cycle 7 pre-dose C trough concentration. The pathological complete response rates of PHESGO were 59.7%, were nearly identical to 59.5% seen with the IV formulation. And the safety profile was also comparable to the IV formulation. Next slide, please. So the next question is, do patients prefer the sub-Q formulation to the IV? Next slide, please. So the France study evaluated that. This was a phase 2 study assessing patient preference. So patients with a HER2 positive early breast cancer who had completed neoadjuvant trastuzumab, pertuzumab chemotherapy and subsequently had their surgery were then randomized to receive in a crossover design to start with 3 cycles of IV trastuzumab, pertuzumab, and then subsequently 3 cycles of PHESGO versus 3 cycles of PHESGO and then 3 cycles of IV. And then treatment was continued as per the standard of care. Next slide, please. And when all things were considered, patients were asked as to which preparation they preferred, and generally the preference was hugely in favor of subcutaneous formulation. So nearly 93% patients preferred the subcutaneous formulation. One of the reasons quoted was less time in clinic, more comfortable during administration, and 87% of those patients who eventually had the subcutaneous as a formulation as a part of the study choose to continue subcutaneous treatment in the subsequent cycles as well. Next slide, please. Most patients again were very satisfied with the subcutaneous formulation compared to the IV. So 88% satisfaction rates for PHESGO versus 68% for IV. Next slide, please. And even the healthcare providers felt that switching from IV to subcutaneous would help save time and resources. So most of the healthcare providers in this study thought that the subcutaneous version was the quickest way of administration, required less resources, and resulted in less drug wastage. Next slide. Even in this trial, when you look at adverse event profile, it was very similar before and after the switch. No new safety signals. Next slide, please. And clearly, the study showing that in terms of patient satisfaction, PHESGO scored over the IV formulation. In terms of healthcare provider satisfaction, PHESGO scored over the IV formulation. And similar to the previous study, there were no new safety signals. The side effect profile was similar. Next slide, please. So very quickly over the next few minutes, some practical consideration for using PHESGO in the real world. Clearly, I think all of us use our nursing partners for the administration, but it's very important to go back to some of the tips to ensure comfortable drugs delivery. PHESGO, since the loading dose is 15 ml and the subsequent dose is 10 ml, there's an element of training that is needed, and Roche has taken that initiative of training most eventual healthcare providers. So ideally, the patient should be sitting back in a reclining chair with the thigh area accessible. It's important that while administration, the level of the chair of the person who's going to administer is going to be similar to that of the patient. The feet of the patient need to be, straight without any twist, bend, or anything. And the injection site is the thigh should be ideally alternated between. Yeah, next slide.
Go to the next slide, please.
The side should be the thigh, and ideally there should be an alteration between the left and the right thigh. And there's no need to split the doses between 2 syringes. So it's 1 syringe that is used for administration. No need to split. Even in a thin patient, there's no need to split. Each new injection site should be at least 1 inch away from the previous site. And it's important to choose the area that is healthy skin, so there should not be any redness, any bruising or tattooing. And it's important to record the use site in the patient notes. Again, to administer the injection, it's important to pinch the skin of the thigh, keep the needle at about 30 degrees. And if at any point of the injection, the patient feels pain or discomfort, the injection should be stopped. for some time before you start again, and keep the needle in place and check to make sure that the needle is in the right 30 degrees angle before you restart. Again, if there is any injection related reaction, then the rate of injection should be slowed or paused, and the injection should be discontinued if the patient has a serious hypersensitivity or anaphylaxis. It's important that while the administration is happening, that the emergency equipment and medications are readily available. And after the loading dose, the patient should be observed for at least 30 minutes for signs of hypersensitivity, which can thereafter be reduced to 15 minutes for maintenance doses. Next slide, please. Now, it's always ideal to have one fixed site for administration that ensures that the patient is comfortable, is reasonable privacy. Obviously, if one is going to do it in a daycare, it's important to maintain patient privacy as well. Next slide, please. So what could Phesgo mean for patients and healthcare providers? Next slide. I mean, clearly, we know that Phesgo means a shorter administration time of 5 to 8 minutes and a shorter observation time compared to the IV preparation. It has less invasive administration, single subcutaneous injection versus 2 separate IVs. It's a fixed dose formulation, so will potentially help reduce the risk of dosing errors, drug wastage, etc. It not only is the drug preparation time lesser, there are also no new safety signals, so it's as safe as the IV preparation. And overall, next slide. What we have seen with the availability of Phesgo is that it's the first formulation in oncology to combine 2 monoclonal antibodies, pertuzumab and trastuzumab, in one vial. The initial studies, the pharmacokinetic studies, showed similar pharmacokinetics for the subcutaneous versus the IV preparation. Clinical efficacy in terms of pathological complete responses in the Frederica study were comparable and were not impacted by body mass index. And next slide. Majority of patients preferred the subcutaneous formulation. Majority of healthcare providers also prefer the subcutaneous formulation. And Phesgo now is FDA and European Medicines Agency approved for same indication as the IV trastuzumab and pertuzumab in HER2 positive early and metastatic breast cancer with or without concomitant IV chemotherapy. With that, thank you very much for your patient hearing, and back to the organizers.
So thank you so much, Dr. Devrat sir, for such an elaborative talk. And so again, because I think this will be a uses for everyone, can we have some more questions? So Dr. Rahul sir, some more questions for your side, your experience, because Dr. Devrat sir has already shared his a wonderful experience with us. Anything from your side, sir?
So I would wanted to ask Dr. Devrat, how's been your experience with the drug? Any challenges, any problems, or very, very convenient?
Yeah, so, surprisingly, it's been very convenient. I had my reservations, when Roche had the initial discussion with me. I had my concerns about 2 things. A, the volume of the injection. B, the fact that with such a large volume, you would need to train your staff. And then I had my concerns about how, a slim patient, and a lot of our patients, especially with advanced breast cancer, do not have a lot of fat. Obviously, we had our staff trained. Now I have about 25 patients who have received Phesgo. I think the one major reason of picking up Phesgo is the fact that it's financially, more affordable compared to the IV preparation. But so far in the 25 patients that we have not had any challenges. And I've had multiple reviews with my team, my nursing practitioners, and luckily no hypersensitivity reaction so far. Obviously, the experience may vary a little bit as the volumes increase, but 25 patients, no issues. I think patients take it very well. It's convenient and no new challenges compared to the IV.
Thank you so much, Dr. Dev.
Hello, Dr. Lokesh from Bangalore. Hello, can you hear me?
Yes.
Yes, sir. Yes, sir. Go ahead, sir.
Yeah, thank you for a wonderful talk. I think Phesgo may replace the IV formulation because it can potentially avoid the need for chemoport for a long duration. So in your practice, subcutaneous administration, all the patients are really convenient for them to administer? Have they any patient experience any kind of infusion reaction or kind of ecchymosis sort of a thing at the site of reaction?
Yeah, so as I said, I think it's been incredibly safe. And I know when you say no reactions, you always start wondering whether the person is telling you a truth or a lie. But unfortunately or fortunately, that's how it's been. So 25 patients so far. North Indian patients tend to be usually a little healthier compared to rest of the part of the country. I've had a couple of patients who were very thin, and even there, no challenges. The real input comes from your, nursing practitioner who's going to administer it, and the patient. So I haven't had any, adverse inputs from either. In fact, before this talk, I called up my nursing practitioner again, tell me if there was any issue that you may not have talked to me about, but there were none. So I think so far the experience has been good. And as I said, beyond the subcutaneous, you've clearly pointed out a significant number of patients who take up Phesgo, do not opt for a chemo port. And as a clinician, I'm okay if they don't go in for a chemo port. Whereas for the IV, you would usually invariably be hell-bent that these patients get a chemo port before you start anything. I think the other aspect is the costing. Clearly, the costing is much more favorable for Phesgo compared to the IV, and that's one of the major reasons, because most of the Indian patients would anyhow come to a hospital. So perhaps the site would remain the same, but the costing is also beneficial towards the patient.
Okay,
So
thank you.
with the interest of the time, so Dr. Lokesh sir, a small request, because unfortunately Dr. Akhil will join in some time. So is it possible, can we have the next speaker, and then once the Dr. Akhil joins, you can introduce? Is it okay with you, sir? He will join, it will take another 10-15 minutes.
Yeah, no issue. Yeah.
Okay, so with the permission, we have Dr. Poonam Patil ma'am. Good evening to you. Is it okay if we take your talk first? Are you okay with? Okay, so thank you so very much for accommodating, and the academic partners for the next session is in task. It's a great pleasure to welcome ma'am, Dr. Poonam Patil ma'am. I think ma'am doesn't needs any introduction, but of course, customary, ma'am is a senior consultant medical oncologist at the prestigious Manipal Hospital from Bengaluru, and ma'am is going to speak on the recent advances in novel formulations of taxane. So good evening once again, ma'am. Over to you for your talk, please.
Yeah, good evening to you all. And it is my privilege to be here with you all today. And thanks to the organizers for inviting me. And may I have my slide set?
1 second, ma'am. You just shared, no?
Shall I try to share, or you will share from your end?
Yes, ma'am, just coming.
Okay. So my today's talk is on advances in novel formulations of taxanes. Now, as we all have seen that when the taxanes first, I remember having administered docetaxel in the year 1998. So I'm talking of 1998, that is how many years back. And I remember that when we were administering docetaxel in Kidwai, we used to sit beside the patient when the docetaxel was started, when it was on flow, afterwards, go and see the patient 10 times, whether the patient is all right or not. And now we have come to a phase where we are very comfortable with taxanes. But this has also been a journey. Let's see what are the advances in novel formulations of taxanes. I thank Intas for providing me with the slides. Next slide, please. So what were the challenges with conventional taxanes? And is nanoaquilip technology a solution to the problems? What are the formulations used in breast cancer, and some data beyond breast cancer? Next slide, please. So you all know, as I was telling you, with docetaxel, we used to be around the patient, hovering around the patient. It was all due to hypersensitivity reactions that we used to face. Next slide, please. So this was a paper in 2010, which said that in the past decade, hypersensitivity reactions with docetaxel were increasing steadily. Next. And the reported rate was approximately 30% in patients who did not receive pre-medications. Despite pre-medications, we used to find some hypersensitivity reactions. Next. And that was the reason why pre-medications with steroids were done, and dexamethasone was started a day prior to docetaxel. Initially, actually, it was 2 days prior to the planned infusion and on the day of infusion and 2 days post-infusion. But now we have come down to only 3 days of dexamethasone, and that has reduced the rates from 30% to 8 to 13%. But still they do occur in these 8 to 13% of patients. Next slide. So it was a renewed call to action. 100% of patients received prophylaxis for the hypersensitivity reactions, and all the reported fatalities due to the polysorbate 80 containing docetaxel and anaphylaxis occurred despite use of prophylaxis. Next slide, please. So the frequency of hypersensitivity reactions with docetaxel, despite pre-medication, led the FDA to issue a black box warning on the package insert. Next slide. So there was another study to study the side effects of the dexamethasone that we were giving to reduce the anaphylaxis of taxanes. So it was hyperglycemia in patients without history of diabetes mellitus, and also infectious complications probably related to the steroid usage. Next slide, please. Amongst the infectious complications, candidiasis was something which was very commonly seen. Next slide, please. So here came a technology to our rescue, which was the nano Aqualib technology. Let's see what it is. It was something to overcome the polysorbate 80, which we were using, that is twin 80, which was being used in docetaxel. Next slide, please. So this is a nano formulation. What does it mean? That there is a hydrophobic portion and there is a hydrophilic portion, and docetaxel is entrapped in between. Next slide, please. So what is the lipid excipient? It is a naturally occurring, generally regarded as safe, also known as GRAS lipid excipients. Next slide, please. Next slide, please. So here the twin 80 was eliminated, ethanol was eliminated, and the usage of this technology did not give rise to any grade 3 or grade 4 hypersensitivity reactions, and there was no need for even steroid pre-medications. Next slide. So just by eliminating this twin 80, see how much advantage we have got. And this is just to delve on the differences between conventional and nano Aqualib formulations. So in the conventional taxane formulation, you have organic solvents like polysorbate 80 or twin 80 and cremophore used for stabilization, which also causes leaching of plasticizers from the PVC bags and IV sets. And hence you have to use specialized containers and specialized sets. Hypersensitivity reactions due to the same, and adverse effects of steroids, which were used as pre-medications. And there was also safety concern regarding the neurotoxicity of these formulations. But in nano Aqualib formulations, these are completely aqueous-based systems. Leaching is not a concern. Grade 3 and grade 4 hypersensitivity reactions are also not a major concern. There are no adverse events due to steroids because they are not used at all. And the initial data suggests lesser incidence of neurotoxicity with the nano Aqualib formulation. Next slide, please. So we know what is nanoparticles actually. So leaky vasculature enables 100 nanometer NDLS, that is the nanosomal docetaxel lipid suspension, to penetrate into tumor tissues. And the tumor tissue has got a leaky vasculature, and because of the leaky vasculature, the formulation seeps into the tumor tissues, and it is where the docetaxel gets separated from the nanoparticle and acts on the tumor tissue. Next slide, please. So in the pharmacokinetics also, the lipid aqualip preparation has got a better delivery of the anti-cancer therapy, that is docetaxel, to the tumor site compared to the conventional docetaxel, that was Taxotere. Next slide. The pharmacokinetic profile of docetaxel was exactly overlapping, as you can see in this, compared with the conventional Taxotere. Next slide, please. So this was an open label randomized multiple dose clinical study of nanosomal docetaxel lipid suspension in breast cancer. Next slide. So this is how the randomization was in a 2:1 fashion for locally advanced or metastatic breast cancer who had failed on prior lines of chemotherapy. And here docetaxel was used in the dose of 75 milligram per meter square every 3 weeks for 6 cycles. And then the primary endpoint was objective response rate. Next slide. As you can see here, the complete responses and partial responses. The blue is the Taxotere, red is the nanoparticle nanosomal preparation of docetaxel, and the complete responders were more in the NDLS arm compared to the conventional Taxotere arm. Also the partial responses, both were more in this novel formulation of docetaxel. Next slide, please. Adverse event profile. Look at the adverse event profile. Almost in all, except diarrhea and neutropenia, which was the same, or little more in the NDLS arm compared to the conventional docetaxel. All adverse events otherwise were better in the novel preparation. Next slide, please. So serious allergic reactions like bronchospasm or swelling of face. No, previous slide. Previous slide. No, I think you've gone ahead. Go to the previous slide. Yeah. So serious allergic reactions like bronchospasm or swelling of face were not observed despite no pre-medication being given. Whereas the same thing was observed with conventional docetaxel. And there was no significant hematological or biochemical deviation in the parameters compared to Taxotere, the native Taxotere. And neutropenia was consistent with those reported for Taxotere. So there was no difference practically in these side effects, but hypersensitivity reactions were significantly less. Next slide. The dose ranging efficacy which was done, as you can see that it was studied at 3 dose ranges, 60 milligram per meter square, 75 and 100 milligrams per meter square in 30 subjects in each arm. And it was every 3 weeks for 6 cycles. Next slide. Next slide, please. As you can see, with 100 milligrams per meter square also, you see the complete responders which were in the blue arm. You saw some complete responders at 100 milligrams per meter square, and even partial responses were better at 100 milligrams per meter square. So the single agent dose was confirmed to be 100 milligrams per meter square as compared to the conventional docetaxel. Next slide, please. So the global clinical development of NDLS, this was a clinicaltrials.gov. You can identify this study, and a global multi-centered 3 arms open label randomized study to evaluate the efficacy and safety of NDLS formulation compared to the Taxotere, that is the innovative brand, with locally advanced or metastatic breast cancer in triple negative breast cancer after failure to prior chemotherapy was taken up. Next slide, please. And this is how it was in the dose range of NDLS 75 milligram per meter square, 100 milligrams per meter square, and Taxotere 100 milligrams per meter square. They were all randomized in 1:1:1 fashion. And no pre-medications were administered in the NDLS arm. Next slide, please. So 50% recruitment has already been completed. The study is ongoing. And the primary endpoint is the objective response rates. And of course, the secondary endpoints would be the safety analysis. Next slide, please. So clinical development of NDLS is actually going on in a variety of scenarios. It's not just in breast cancers. Studies are ongoing for squamous cell carcinoma of head and neck, non-small cell lung cancer, metastatic prostate cancer, and metastatic gastric adenocarcinoma patients as well. I will not go into the details of this as today's meeting is specifically related to breast cancer. Next slide. Next slide. So this just showed that how the NDLS formulations had a good response rates despite being not in the breast cancer, in the other cancers as well. Next slide, please. Next slide, please. As I told you, I will not go into these. So this is about head and neck cancers. Again, studies are going on. Next slide, please. Results again show good response rates. Next slide. Yeah, so NDLS-based neoadjuvant chemotherapy in patients with breast cancer. This was a prospective observational study in which patients with stage 2B or 3 breast cancer received neoadjuvant AC followed by docetaxel, in which there was randomization between conventional docetaxel as well as NDLS. And the dose was 75 milligrams per meter square every 3 weeks for 4 cycles. Next slide, please. This was presented in ASCO as well. And as you can see that the baseline demographics were quite similar. Next slide, please. Again, the baseline demographics being similar. Next slide, please. So pathological response rates, you can see in the NDLS arm were significantly higher compared to the traditional docetaxel arm, and similarly were the clinical response rates. Next slide, please. The grade 3-4 infusion-related reactions, hyperglycemia and neuropathy were noted in the conventional docetaxel arm, while it was not reported in any patient in the NDLS arm. NDLS-based NACT or adjuvant chemotherapy was efficacious in the treatment of breast cancer and showed comparable pathological complete response rates and overall survival rates compared to conventional docetaxel. Next slide, please. So we know about docetaxel as a nanosomal suspension, and a few years later, there was paclitaxel also available from Intas in form of a nanosomal paclitaxel lipid suspension. Next slide, please. So here also, this was a study 113-10, where it involved breast cancer patients who had failed on prior chemotherapy, of course, non-taxane based, and they were randomized to NPLS, that was nanopaclitaxel lipid suspension in various doses, 175, 80, and Taxol was 175 milligrams per meter square, all given every 3 weeks. And the 80 milligrams per meter square was every week for 18 doses. This was every week and others were every 3 weeks. So the duration of therapy was 18 weeks and the primary endpoint was objective response rate. Next slide, please. So the overall response rates showed that weekly the paclitaxel, that was the lipid formulation, was better compared to the 3 weekly formulations or 3 weekly schedule of paclitaxel, whether it was NPLS or the conventional Taxol. But in the NPLS, which was given every 3 weeks, was superior to the conventional paclitaxel as well. Next slide, please. Next slide, please. So this was another study which was presented in ESMO this year, where breast cancer patients who failed on chemotherapy again when randomized to NPLS versus Taxol at 175 milligrams per meter square. And then the primary endpoint was objective response rate. Next slide, please. This was how they were randomized. Next slide, please. This was a poster presented by Dr. Satish, the previous one. baseline characteristics similar. Next slide, please. This study we have seen earlier. I think there's a little mix-up of the slides. Dr. Satish slides these were. This is the study presented by him in this ESMO. The response rates again clearly show the benefit of NPLS. Next slide, please. Arm A was once in 3 weeks NPLS, Arm B was weekly NPLS, and Arm C was the conventional Taxol given every 3 weeks. And the side effects were comparable or even lesser compared to the conventional paclitaxel. Next slide, please. So A is of special interest. With conventional paclitaxel, it is the neuropathy, which we are very worried of because it's a very disabling symptom for the patient. But you see, for percentage-wise, it was almost same or little lesser compared to the conventional paclitaxel. Next slide, please. So there was reduced incidence of all grades neuropathy with NPLS formulations. Next slide, please. This was another study in ovarian cancer, which is a multi-center open label randomized study to evaluate efficacy and safety of NPLS in patients with platinum resistant or refractory metastatic ovarian cancer, and the recruitment is ongoing. Next slide, please. Then there is also a formulation of oral cabazitaxel. Since we are talking about novel taxane formulations, oral cabazitaxel is indeed a novel formulation. And there is an open label multicentric study to determine the maximum tolerated dose. And it's a phase 1 study which is ongoing for dose escalation. Next slide, please. So it is a nanoaqualip technology, is a lipid-based platform technology for difficult to formulate, poorly water-soluble drugs. Advantages are that it is a complete aqueous-based system. Next. Free of hazardous organic solvents such as tween 80 or chromophore. Next. Particles are nano size, 100 nanometers or less. Next slide. All excipients used are naturally occurring lipids, that is GRAS. To conclude, serious adverse events like hypersensitivity reactions are common with docetaxel and paclitaxel. And to avoid them, we need to use corticosteroids, which can themselves worsen hyperglycemia and increase risk of infections beyond what chemotherapy would have given. NDLS and NPLS are free from solvents and can be administered without steroid premedication. And despite not giving any premedication with steroid, no grade 3 or 4 hypersensitivity reactions were observed. And oral cabazitaxel is also a novel formulation, which could be a new management option for patients with relapsed refractory cancers. Next slide. Thank you very much. Thank you.
Thank you so much. Thank you so much, ma'am. As always, such a elusive talk. But there must be some question which can be taken in the chat box with the paucity of time. We move forward to the next session, and it's a pleasure to welcome and invite Dr. Lokesh K.N., Associate Professor, Kidwai Memorial Institute of Oncology at Bangalore. Good evening, Dr. Lokesh. If you can just invite the next speaker, Dr. Akhil Kapoor, he's there.
Yeah. So good evening, everybody. I'd like to thank the sponsors for giving me this opportunity. So now I'd like to welcome Dr. Akhil Kapoor, Assistant Professor, Medical Oncology, Tata Memorial Hospital, Varanasi. He will be talking on navigating management of HER2-positive early breast cancer. The main focus is on TDM1. Over to you, Dr. Akhil Kapoor.
Thank you. Thank you. So definitely the management of HER2-positive cancer has evolved, and we have now the availability of some of the drugs, especially in the generics, because we know we deal with a situation where the costly medications are affordable for a very small subset of the patients. So we need more and more generics, and that is why this drug, the TDM1 generic, has actually helped us and not only metastatic setting, on early breast cancer as well. We'll see some data for the same. Because we know the prognosis of HER2 positive disease is really poor. In absence of HER2 targeted treatment, it is very dismal. You can clearly see the graph, the differences are huge. And we cannot imagine a treatment of HER2 positive breast cancer without HER2 targeted disease now, because now we have very affordable options in terms of trastuzumab. So there have been multiple HER2 targeted treatments. Trastuzumab deruxtecan is the nearest addition to the same, and it will be going to be available in country, but the cost remains an important issue. And the just a drug which was just previous to it, that is TDM1, now the generic for TDM1 is available to us. That has made us some significant contribution. So let's see the data for adjuvant treatment. This is the data for adjuvant trastuzumab. We know that this has significantly improved the outcomes for our HER2 positive patients, not only in PFS, DFS, it also in terms of overall survival. And we were talking about 6 months versus 1 year. TMH meta-analysis is there in a selected subgroup of the patients. Even 6 months of trastuzumab might be considered when it is not feasible to give complete 1 year. But still, these patients, as we see, node positive patients and patients who are T2 to T4 and hormone receptor negative, these patients tend to have poorer outcomes, and the hazard ratio is the tune of 2. So these patients do not so well as with other treatment. So what to do in neoadjuvant treatment, what to do in adjuvant treatment? Neoadjuvant treatment, we all know now all the patients who are node positive, who are having T3, T4 disease, these are considered to be given neoadjuvant treatment, especially in HER2 positive and triple negative patients, because we know that we have some additional treatment available with us now in HER2 positive as adjuvant TDM1 and triple negative adjuvant capecitabine in our patients. That is why we try to see the best possible responses in these patients. If we see the higher risk HER2 positive early breast cancer, these are the patients who have a risk of more than 10% recurrence. Any patient with residual disease or any patient who had the baseline node positive or T3, T4 to begin with, these patients are known to have somewhat poorer outcomes, especially patients with having residual disease. Hazard ratio is to the tune of 0.31. So patients with PathCR, they have so good outcomes in terms of event-free survival. And also PathCR is somewhat associated with improved overall survival. This is the data. There is always a confusion regarding the PathCR and OS, but yes, PathCR is taken as a surrogate marker for overall survival, especially in breast cancer. The story is not same for all the tumors, but yes, in at least in HER2 positive and triple negative, we know that PathCR is associated with better tumor biology and responsive tumor biology. So TDM1 got approval for this setting in 2019. Trastuzumab is also now available, but PER2 is still not available as generic. Neratinib, this is available, but the toxicity and additional cost after 1 year of the treatment, completing the adjuvant treatment, it makes it very difficult to utilize in the real practice. So practically no utilization of neratinib in our practice. This is the Catherine data. We are very well aware of the same. This has been one of the very important aspect. If you see the TDM1 versus trastuzumab maintenance treatment after completion of the treatment with primary endpoint of high invasive disease-free survival, you can see the patients who were given trastuzumab alone in pre-op treatment were 80% in both the arms. So patients who are getting trastuzumab plus PER2 in the new adjuvant arm, they are also a category one recommendation for TDM1 adjuvant if they do not get PathCR. Similarly, early around 15 to 20% patients in both arms receive trastuzumab plus PER2. And also, you can see the invasive disease-free survival difference was to the tune of 11% with 50% reduction in the risk of recurrence with the utilization of TDM1. And you can see the patients who are hormone receptor negative or positive, they were having the similar benefit with TDM1. Patients who did not get pertuzumab also had a significant benefit. Even patients who got pertuzumab had significant benefit. Node negative or node positive node status after pre-op treatment were having somewhat similar benefit as per this forest plot. If we see the distant recurrence rates, yes, it has significantly improved. We know that TDM1 is a highly effective treatment. It has inherent chemotherapy property as well, while trastuzumab is only a targeted treatment, and you can clearly see a significant reduction in distant recurrences. Now, OS trend is also towards the same, but will require much more follow-up for overall survival. If we see the affinity data, this has come now. After 10 years of follow-up, we know that node positive patients will get the maximum benefit, while in node negative, there's no much benefit of utilizing adjuvant pertuzumab. That is why node negative patients, we have now stopped utilizing adjuvant pertuzumab, and we continue on only on either TRUST-II or patients who have received neoadjuvant treatment completely, the adjuvant TDM1. This is the XTNet for neratinib study. As I told, neratinib has shown some benefit in terms of IDFS, which is to the tune of 5% and 7%. But the problem is the toxicity. Any treatment in the adjuvant setting should not only able to increase the survival, but also should be very well tolerated, because we are talking about a adjuvant treatment where quality of life is really, really important, because if the treatment is very toxic, most of the patient will not take it. So that is what happens in the real practice as well. So these are the three available options. Now with the availability of TDM1 generic biosimilar, it has become very much utilizable. And if we see, this is now the guidelines, patients not getting PAT CRs for HER2 positive treatment who received treatment with chemotherapy with trastuzumab plus minus pertuzumab. These patients not getting PAT CR, TDM1 is now a standard recommendation for the same. So with this, I will summarize. The CATHRIN data has been the most important for us. With patients who are having residual invasive disease, TDM1 is now a very good adjuvant treatment option in these patients. Affinity, it has shown that only node positive patient will get some benefit from pertuzumab. Node negative patient do not tend to get any benefit. Neratinib, though approved treatment option, it is utilized in very few patients because the toxicities and available logistic constraints, and also it is not available in India. With this, I would like to stop here. I would like to take any questions if there are.
Yeah, thank you, Dr. Anil Kapoor, for a wonderful talk. So I have one or two questions. So patient received a neoadjuvant TCH 6 cycles post surgery histopathology showing DCIS. So should we really escalate, or should we continue the same, or can we de-escalate to trastuzumab? That is one.
Yeah, so DCIS patients who are non-invasive tumors, I think that will not require escalating to TDM1. Also to understand, any treatment like TDM1, though TDM1 is comparatively well tolerated, but still it is a drug with trastuzumab plus one of the chemotherapy drug. So definitely toxicities will be somewhat higher than trastuzumab. We need to do CBC with TDM1 while it is not required with trastuzumab. So where we know the benefit is going to be minimal, would not like to utilize a toxic treatment, but to utilize a treatment option which is much better tolerated and gives the similar benefit.
Should we de-escalate to only trastuzumab, or should we continue pertuzumab with trastuzumab if we have used a dual agent?
So yeah, that will depend on the baseline node positivity. If the patient was node positive, adjuvant TRUST-II plus PERT-II can be considered, but if patient was node negative, I would give only TRUST-II in this such patient.
Okay. So one more thing is before neoadjuvant clinically node positive, post-surgery histopathology, it comes node negative. So should we add pertuzumab based on the clinical finding, or should we go with histopathological finding?
So that depends on the baseline, your clinical judgment. If you think, though histology or FNSC was not done, but if you are sure that radiological findings and your examination findings were in favor of metastatic node, then you can continue TRUST-II plus PERT-II. But if you think the patient has just a reactive node, I don't think addition of PERT-II will help based on the data which affinity has shown. And also, since the patient has received TCH alone till now, a patient has not received pertuzumab in the neoadjuvant setting. If this is the scenario, addition of further PERT-II is doubtful in such scenario. We don't have very good data for the same.
Okay, thank you. Any questions from anyone?
Yeah, Dr. Lokesh, could I ask a question to Dr. Akhil? Dr. Akhil, the triple positive subgroup of patients, metastatic triple positive, many of our patients will progress on the Cleopatra, and they still remain triple positive. So what is your experience of combining the TDM1 with other chemotherapeutic agents, or with probably CDK4/6 inhibitors, or fulvestrant or hormonal treatment?
So we have utilized combination of hormonal treatment with one of the chemotherapeutic drugs like capecitabine or TDM1. But we have not utilized CDK4/6 along with one of the chemotherapy. This is the usual practice till now, because we know that chemotherapy will have its own neutropenia, and CDK4/6 will also cause neutropenia and will cause profound. If the two agents are non-additive toxicities, then that can be considered based on the clinical scenario. But if the toxicities are somewhat similar, I think it will make quality of life poorer. So that is how we decide the treatment in real world practice. I think you will agree to the same.
It's a gray area, I'll say, because triple positive metastatic breast cancer, we try to cover the HER2 as much as possible, but the hormone part of it, like I had a triple positive patient where I combined the TDM1 with fulvestrant, but unfortunately the patient developed liver toxicity in the form of transaminases. So then I had to stop the fulvestrant, continue the TDM1, hoping that the chemotherapeutic partner along with that works, and it did. But yes, this is what we did. But heart of heart, I know I'm just covering the HER2 part of it. I'm not covering the hormone part of it.
Yeah, most of the time the driver in such scenario is also HER2, so it is more important to cover HER2 as per the traditional teaching and experience as well. So I completely agree. You should cover HER2, and if ERPR is very strongly positive, like 6 or 8 already scores, then you can utilize one of the mild hormonal agents which do not have overlapping toxicities.
So thank you so very much. Thank you, Dr. Lokesh, for moderating this session. Thank you, Dr. Akhil and Dr. Rahul Sood for making it interesting. So we are coming to the last but a very, very interesting topic, and it's always a pleasure to welcome Dr. Chetan Deshmukh, sir. Dr. Chetan, sir, a very good evening from all of us. Sir doesn't need any introduction. Seems like he's still at Dinanath Mangeshkar Hospital. Hello, sir. Good evening. Yeah, so sir is a senior consultant medical oncologist at the prestigious Dinanath Mangeshkar Hospital and Research Center, Pune. Sir, thank you so much for joining. And sir is going to talk on the management of triple negative advanced breast cancer. Sir, over to you. You can share the slides, please.
Yeah, just give me a minute. Am I audible?
Absolutely fine, sir.
Fine. So I am aware that I am standing between you people and your well-deserved dinner. So I'll try to keep myself limited to the time allotted. I'm going to talk on metastatic triple negative breast cancer, which we know it's a phenotypically one disease. We've grouped it all into one common heading, but molecular wise, it's a heterogeneous disease. We have at least 6 subtypes identified: basal-like 1, basal-like 2, mesenchymal stem cell-like, immunomodulatory, and luminal androgen receptor positive. These tumors don't have an actionable target, and hence we have tried multiple options, and quite a few of them have not done very well. And that is why success has been very, very varied between groups of these heterogeneous population. We typically decide treatment for metastatic disease based on symptoms, age, performance status, prior therapies, and in recent times, if there are any actionable targets. Now, I'll be talking a little bit about these actionable targets which have recently emerged on the landscape of treatment for triple negative breast cancer. Conventional chemotherapy has been the backbone of treatment for patients who have triple negative disease. And of course, we've now started using immunotherapy, antibody drug conjugate therapy, though not available in India, and some targeted agents like PARP inhibitors. Targeted therapy like bevacizumab, though it has been taken off the list of the approved therapies by the US FDA, I see a fair amount of patients being treated with a combination of taxane with bevacizumab, with or without carboplatin. So in India, especially when generic bevacizumab is available, it remains an option which is utilized by many. There are some novel therapies also coming up in PIK3CA inhibitors like capivasertib or anti-androgens. For biomarker negative, triple negative breast cancer, chemotherapy is the standard choice for frontline. Whether to use monotherapy or combination has always been a question. Combination is preferred for rapid relief and better response, but it has its own share of toxicity. So taxane monotherapy, especially in the elderly population, or an anthracycline combination is the most preferred option. And patients who have failed anthracyclines, then eribulin is another good choice, which has very minimal toxicity and fairly manageable short infusions and less neuropathy. Subsequent therapies are, of course, decided by patient's performance status, her organ functions, and response to prior treatments, and of course, the disease-free interval, and if there are any residual toxicities of previous treatment. So beyond conventional chemotherapy, we know that the success with chemotherapy has been limited. One. Second, you cannot go on giving chemotherapy beyond a particular time because of the cumulative toxicities. So we have always been looking at additional options, one of which has been immunotherapy. PARP inhibitors is coming up, and an antibody drug conjugate like sacituzumab govitecan. Now, triple negative has traditionally been a low-hanging fruit in breast cancer. A lot of research has gone into its making, and we are now getting more and more targeted treatments. Earlier, it was thought that no targeted treatment is going to work in this group, but we are now getting a fair amount of targeted treatments for treatment of metastatic triple negative breast cancer. Because there was no target, immunotherapy was one of the obvious candidates to be used in this setting. The toxicity of immunotherapy, we all have been using it for the past 3-4 years now, and it is fairly manageable. Once you get used to using these drugs, then the toxicities, you can predict the toxicity, recognize it in time, and go ahead and treat it or even prevent it. You can combine it with chemotherapy so that you can benefit from the immunomodulatory properties of conventional chemotherapy, and that is why combination of immunotherapy with or without chemotherapy has been a very attractive option in triple negative breast cancer. The results of standalone therapy they have not been very great. Typically, single agent pembrolizumab, atezolizumab, or avelumab, which have been the drugs tried, the overall response rate has been less than 20 or barely 20% or so. In the PD-L1 positive population, the response rate has been slightly better. The atezolizumab monotherapy study showed that if you have patients in all comers, the median overall survival was 8.9 months. But if you have a PD-L1 positive tumor, the median overall survival is slightly better. So then came this study where this was one of the first studies where they used atezolizumab with nab-paclitaxel, or the other arm had nab-paclitaxel with placebo, atezolizumab in the dose of 840 milligrams every 2 weeks. Remember, there was no crossover allowed in this study, and the co-primary endpoints were PFS and OS. In the intent to treat population, you can hardly see any difference. Both the curves almost appear overlapping. But in the PD-L1 positive subset, there is a slight change in the curves, and you can see some separation right at the top. And numerically, the overall survival is slightly better with 7.5 months with atezo compared to 5 months with chemotherapy alone. The overall survival also numerically, the median overall survival is 25 versus 18 months. And this was again in the PD-L1 positive population. So emboldened by this success, there was another study which also used another immunotherapy agent, pembrolizumab, with chemotherapy or placebo with chemotherapy. The chemotherapy was the choice of chemotherapy was left to the physician, which included either nab-paclitaxel day 1815 of a 28-day cycle, conventional paclitaxel, or gemcitabine with carboplatin, the primary endpoint being progression-free survival and overall survival, and the secondary endpoints being overall response rate and duration of response. Now, this study, while treating, they had all comers, all patients with adult triple negative metastatic breast cancer, but they had stratified these patients based on their PD-L1 positivity also, either intent to treat, that is the all comers, PD-L1 with a combined proportion score of more than equal to 1 or more than equal to 10. In the intent to treat population, you can see that the PFS numerically doesn't appear very encouraging, 7.5 versus 5.6. Nothing very great. In the patients with PD-L1 scores more than 1, again 7.6 versus 5.6, nothing much to talk about. But in the population which has a CPS of more than 10, the median PFS was 9.7 versus 5.6. Now here you can actually see a difference of almost 4 months. So this, based on this, and again, adverse events in this study were minimal and fairly manageable. And you can combine immunotherapy with a choice of chemotherapy. So based on these results, pembrolizumab with chemotherapy has now been approved for metastatic triple-negative breast cancer in patients who have a PD-L1 score of more than 10%. Then coming to the next group of drug, antibody-drug conjugate, sacituzumab govitecan is it's an antibody to TROP-T, which is an anti-trophoblast cell surface antigen, and that is coupled to the payload of SN38, which is the active metabolite of irinotecan. Now, the anti-TROP2 monoclonal antibody binds to the TROP2 expressed on the tumor cell surface, and it allows the targeted delivery of SN38 to the tumor cells. SN38 is also a membrane permeable agent, and it may have some anti-tumor effects in the adjacent cells also, which may or may not be TROP2 positive, but this bystander effect may be occurring as well. This drug was tested in the ASCENT study, patients with metastatic triple-negative breast cancer who had failed at least 2 lines of prior therapy, which also included taxane. They also permitted patients with brain mets. These patients were randomized to sacituzumab govitecan 10 mg per kg on day 1 and day 8 and every 21-day cycle, or physician's choice of single agent which had capecitabine, eribulin, gemcitabine, or vinorelbine. These are our standard treatment options. Now, this trial actually was halted early based on efficacy as per unanimous recommendation of the Data Safety Monitoring Committee. The progression-free survival in patients without brain mets was 5.6 months. The median PFS in the sacituzumab arm was 5.6 months compared to 1.7 months in the chemotherapy alone arm. Now, this is a little surprising because 1.7 months is a very small interval. I wonder whether we actually see such a kind of scenario in our practice. Most of our patients do cross 4 to 6 months, even with conventional chemotherapy like capecitabine or gemcitabine. But maybe these patients were heavily pre-treated. The overall survival was almost double. With sacituzumab, the median overall survival was 12.1 months compared to 6.7 months with conventional chemotherapy. The forest plot showed that almost all subgroups, whether your age was less than 65, more than 65, the number of prior therapies, prior use of PD-L1 inhibitors, liver mets, yes, no matter whatever subset was taken into account, sacituzumab showed better efficacy in all these subgroups. Remember, the payload is SN38. We all know irinotecan is not an easy drug to handle. Some of our patients have very, very troublesome toxicity, and at times in certain metastatic scenarios, we've even burnt our fingers and have had life-threatening toxicities with irinotecan. So this drug also can cause neutropenia, leukopenia, diarrhea, which is again a common complication with irinotecan derivatives. Anemia and febrile neutropenia were also seen. So concomitant GCSF use, discontinuation rates were also higher with sacituzumab govitecan. Nevertheless, it showed promising efficacy in all subgroup of patients with or without brain mets and in the elderly population as well, though adverse effects continue to remain a concern. But if you look at the better response, there is better progression and overall survival. It makes a very promising therapy in patients who failed early on chemotherapy and may not be eligible for immunotherapy. So this would be a drug to watch in the next few years to come. Now, patients who had germline BRCA mutation, for these patients, if they can be offered a PARP inhibitor, this was a study in the metastatic setting, though it was not necessarily a triple negative patient population. It had a mixed population, but if you see the patient population, triple negative form almost 50% of the entire population. So fairly good number of patients had triple negative disease. These patients who had received anthrataxane and had not received more than 2 lines of chemotherapy for metastatic disease, these patients were randomized to olaparib 300 milligram twice a day versus chemotherapy as a 28-day cycle. And apart from that, most of their baseline, all these patients had to have a germinal BRCA mutation. the overall survival in the triple negative group was not very different, 17.4 months versus 14.9 months. This difference was not statistically significant. Nevertheless, this, and of course, it has its own share of adverse events. We have been using olaparib in ovarian cancer, and we know that hematologic toxicity is definitely a very real concern. A fair amount of patients develop anemia and at times even thrombocytopenia. So all grade A's were seen in more than 15% of patients, but grade 3 or above, that is more severe adverse events, were seen in a much smaller proportion of patients, of which anemia and neutropenia were the major toxicity concerns as far as the use of olaparib was concerned. So, treatment of triple negative breast cancer remains a challenge. Chemotherapy is definitely an important option, but with newer molecules now, in the past 5 years or so, we've suddenly started seeing a spate of new molecules, new targets being identified. We have sacituzumab, we have pembrolizumab. These appear to be quite promising, but we will also need better biomarkers to identify who will benefit from these therapies. Some of them are toxic, either physically or financially. So we'll have to pick and choose our patients so that we can achieve the most out of these drugs. And there may be some benefit from PARP inhibition. There are some newer targets being identified, like PIK3 and luminal androgen receptor. And so this would be a space to watch in the next few years to come. Thank you.
Sir, thank you so very much for such a brilliant talk, as always. And I hope everyone would have enjoyed this. So Dr. Sood, any questions? Anybody, if Dr. Akhil, you are there, Dr. Pooja ma'am, if you're there, any questions to sir? So can you hear me, Dr. Sood, sir? Can you hear us? Hello?
Yes, we can hear you. We
can hear you.
Yeah. So, Dr. Akhil, any questions for Dr. Chetan Deshmukh, sir? I think such a lucid talk and many questions. Sir has covered the major topic for TNBC.
Yeah. So just the actual utilization of IO in triple negative breast cancer, sir, after the negative data from Atezo, at least we have stopped completely utilizing Atezo in TNBC. But how about Pembro? How about your actual utilization in the clinical practice, and how are your experience?
Pembrolizumab, well, Atezo, I agree that the data has not been very great, but Pembro with a CPS of more than 10 looks like it is there to stay, and it will probably be used more and more in this space. So we'll need to make sure that not just PD-L1 positive, but PD-L1 positive more than 10. Those are patients who would probably benefit more out of Pembro. And there are other studies also. Actually, there are other studies which I did not include for sheer want of time, but they are trying to use immunotherapy with oral endoxan. Also, there are studies with nivolumab as well. So in principle, these were studies which I thought were the ones which set the ball rolling in immunotherapy. There will be other molecules, other combinations also tried. But right now in triple negative, at least in the neoadjuvant setting, we have a good amount of data from the Keynote 522 study. So in the metastatic setting also, I think that for patients who have a high PD-L1 expression, it would be a good option.
Yes, sir, completely agree. Sir, in a specific setting where TNBC patient recurring only in brain, what is your suggestion for the systemic treatment? Because most of the time we see these patients have recurred only in the brain, have received whole brain radiation, and also some boost, SBRT boost if feasible, to the brain, and there is no other disease throughout the body. In such cases, how do you select the systemic treatment in such patients?
If we are looking at only brain mets, then And if the patient does not have symptoms pertaining to systemic, to rest of the systems, we tend to go a little conservative. If the patient is suffering only in the brain, then only brain-directed therapy is offered. Most of our drugs don't have a great intracranial penetration, but it would be interesting because there has been some data on deruxtecan used in HER2-low subset as well. So if that data shows some promise in triple negative, it would be a drug which can be used at a later date. But of course, that drug also is looks like a fairly toxic drug. So if a patient has no symptoms, systemic symptoms, I would probably stick to only therapy related to his brain.
Okay, sir. Okay, sir. In our practice, most of the time we utilize some form of the treatments because, for example, capecitabine or a somewhat gentler treatment if feasible, because we know that the drugs which are able to penetrate the brain will be more important. I completely agree with you, sir.
So I wanted to ask you a question.
Yes.
We know that the data in first line metastatic triple negative breast cancer, where pembro plus nab-paclitaxel is an approved option now. But we have some patients who have probably gone through the grind of 2 or 3 lines of therapies, chemotherapy and all, and suddenly we can offer them a single agent pembrolizumab, though the data is not there. Any such experience, those patients who are going on for past 1.5 to 2 years, maybe exhausted, even eribulin, capecitabine. So would you be tempted in giving single agent immunotherapy, though the data is not there?
Yeah, the standalone, I showed the slide on standalone response rate. The standalone response rates are really very low. 21% was the highest. So in the metastatic setting, no doubt survival is an important endpoint, but even the response rate remains an important consideration because that is going to achieve palliation faster. So if the response rate is so low, if it's just 20% or so, using single agent may not be a good idea. But I'm sure there are combinations coming up with even oral cyclophosphamide or some such drugs. They are coming up with immunotherapy. So as we get to use these drugs more and more, once these drugs become a little more affordable, we'll probably have combinations with almost everything. Single agent, we'll have it with oral metronomic, with injectable chemotherapy, all kinds of, maybe with some other targeted agents as well.
So we continue to have a good discussion, but I think we are bang on time. Thank you so much, Dr. Chetan sir, for such a lovely presentation and the time you have spent. So before we close, the final words from Dr. Rahul Sood, and then I think none of us would like to come for in between the dinner. So Dr. Rahul Sood sir, over to you with your final comments and remarks, and then please allow us to close.
Right. So, my job is to give you the appetizer before the dinner. So I would like to thank everybody who joined for the past 2 days. Yesterday, we had a discussion on the molecular diagnosis of breast cancer, followed by early breast cancer, the neoadjuvant and the adjuvant treatment. And today, again, we had the continuation of the same in the form of the advanced and metastatic breast cancer. So it's been a feast, appetizing feast, if I can say. So I would like to thank all those people who joined and listened to us and interacted with us. Thank you to all the speakers, to all the panelists who were there. And I think such topics really refresh us as we go forward. Well, this meeting would not have been complete without the team, that is Tarunji as well as Ektaji and her team who have organized this extremely well. So a sincere thanks to your team for conducting a spotless presentation, keeping it bang on time, and for that. So thank you once again. Wishing each and every one a happy, a very safe Deepavali and a festive season ahead. With this, I hand you to Tarun and his team.
So thank you so much, Dr. Sood sir, for such a kind words on behalf of my colleagues, specifically Mahima and Ankit. They have worked very hard for this meeting. Thank you so much, team. And it's as you very well said, sir. So thanks to our esteemed faculty, the speakers, the moderator, and panelists for spending such a wonderful time. And from all of us from the organizing team, it's a time to say a happy Diwali, stay safe, stay blessed, enjoy the festivities with your families. Thank you so much.